was around where they indicated that there was like 250 odd in beds that they could open in an emergency. And he was asked a question about how would they staff those beds, to which we got a complete non-answer. And I do think that staffing is such a huge issue that we should particular specialism on duty that night. So staffing and safety staffing is already an issue, and if we have a flood of flu or respiratory disease, I'm not sure how you'd open those additional beds and put more pressure on staff. That's just, if that's okay with everyone, I think.
Everybody content with that?
Content. Chair, the Minister was also asked by me about the figure for the additional sessions, of which he quoted 2.5 million, but I had also asked him how that compared to last year's Wonder Plan, and he didn't provide an answer to that. So I think we know the answer, but I think it's worthwhile highlighting that to him, that there's certainly a difference from what was provided last year to what is being provided this year.
Yeah. If we write to the Minister in relation to those issues, and obviously the Minister's coming in before us, not too distant future as well, so I'm pretty sure he'll get asked further questions. Everybody content? Okay, so just moving on then to the main substance of today. So item 5, an oral briefing on the departmental intervention with regard to the Belfast Trust. Can I refer members to the papers, which are tab 5, page 18 of the main pack, and also in our tabled papers as well. And can I welcome Peter McBride, external expert within the departmental intervention team, and also Jennifer Hill, external expert within the departmental intervention team. So we've got your report and we've read it. If you want to make some opening remarks, that would be great, and then we'll go straight to questions from members.
Would it be helpful if we did a brief introduction of ourselves? Just, I think, particularly maybe for Jennifer. So, Peter McBride. I spent most of my career in leadership in the voluntary and community sector. The last 6 or 7 years I've worked across the public sector, particularly in health and particularly around culture and the openness, duty of candour, that sort of thing.
Hello everyone, I'm Jennifer Hill. I'm from Belfast originally, but have lived and worked in England and Scotland for a number of unspecified decades. Working most of my clinical life as a consultant chest physician for over 20 years, and then laterally as a Chief Medical Officer of a similar sized trust in Yorkshire until earlier this year. So that's my background.
By way of introduction, we thought we'd talk you through a little bit of the process. It won't take very long, and we won't go through the content and the assumption that you've read it. So if we just talk a bit about process, and then we'll take questions on content. This has been a challenging piece of work. We've heard lots of very difficult stories. The intention of it right at the start was to be as inclusive as possible. So we created multiple ways in which staff within the Belfast Trust could engage with us. The first of those was a survey that we put out to all staff. This was back towards the end of June and July, where the Belfast Trust facilitated a video. On the back of that there was a survey, and in response to that we got 3,429 responses, which we were very happy with. That survey allowed people they could respond to that anonymously, which many of them did. But it also asked some high-level questions about their experiences of raising concerns, particularly whistleblowing. It also afforded the opportunity for those who wanted to take a step further, if they wanted to give us their email addresses, that we could follow up for more detailed information. And out of that 3,429, 710 indicated that they wanted a follow-up. So we followed them up. We got more detailed information from them that allowed us there were some free text opportunities that allowed people to tell their stories a bit. But critically, as part of that also, it allowed people to say whether they wanted to engage with us face-to-face or in some shape or form. So out of that 710, a further 138 indicated that they wanted to tell us their stories. And so over a period of through a variety of mechanisms, face-to-face meetings, group online and face-to-face online, we met with those people. So that's the first group, and we got a lot of data that you'll see in the report from that group, and I'll talk about that. We can talk about that in the course of the meeting. The second category of people are people who, off their own bat, contacted us, and many of those people would have been prompted by you. They will have contacted you, and then you'll have directed them to us. So we offered all of those people the opportunity of individual contact, and again, we spent quite a lot of time speaking with them and listening to their stories. And then the third category of people are the people that we sought out. So these are people who did not necessarily approach us, but who, for reasons, strategic reasons, because we were interested in a particular area of work, and these are particularly the medics, we sought them out. I'll maybe ask Jennifer just to expand a little bit about how we did that.
Yeah, so there clearly was some overlap between our two kind of terms of reference, and you see those in the report of what we were asked to look at. I was particularly asked to support the team around the response to the cardiac report, but also to look at systems and processes that the board oversaw, quality, governance, and the medical leadership model. So I spent a fair bit of time talking to the senior leaders, both clinical and non-clinical, the governance teams, and a number of clinicians. I also attended some clinical areas and some governance meetings to get a sort of hands-on understanding of how things worked, and also reviewed a number of policies and minutes of meetings to understand reporting in particular. So slightly different approaches, but clearly an overlap between the work of Peter and I.
So in total, we believe that there were over 370 interactions. Some of those 370, most of those 370 were with individuals, but some of those 370 interactions were with groups of people, as Jennifer has described. So we believe that everybody who wanted to speak to us about this got the chance to do so and to have input into it. And what we have earnestly tried to do in this report is to honour the stories that we heard. I think this has been difficult. Some of the stories have been difficult to hear. We've tried to be proportionate and balanced in what we've presented to you, but we have tried. And
a number of clinicians. I also attended some clinical areas and some governance meetings to get a sort of hands-on understanding of how things worked, and also reviewed a number of policies and minutes of meetings to understand reporting in particular. So slightly different approaches, but clearly an overlap between the work of Peter and I.
So in total, we believe that there were over 370 interactions. Some of those 370, most of those 370 were with individuals, but some of those 370 interactions were with groups of people, as Jennifer has described. So we believe that everybody who wanted to speak to us about this got the chance to do so and to have input into it. And what we have earnestly tried to do in this report is to honour the stories that we heard. I think this has been difficult. Some of the stories have been difficult to hear. We've tried to be proportionate and balanced in what we've presented to you, but we have tried to honour the testimonies that we heard from the people that spoke to us. So happy to take any questions you have.
Okay, thank you very much, and thanks very much for the work that you have done in relation to this. So obviously, this report is done on the back of another report which identified poor behaviour and culture within the Belfast cardiac surgery unit, and that was on the back of previous investigations and work. And yet, in this most up-to-date report, you are telling us that there is still significant risk associated with the dysfunctional team dynamics within the cardiac surgical team. Despite the passing of all of this time and despite the number of reports and the media attention, how concerned are you about the fact that this is still a problem given all of the investigations into that unit?
Want me to start?
Yeah.
So I suppose I'd say two things. We were asked clearly to comment on where we are now and what the team have been doing, and I think you've raised the fact that we've mentioned ongoing risk. So I guess when I'm looking at this as an ex-CMO, I'm saying, would I feel content with a relative of mine going into that cardiac surgery unit this week to have an operation? That's my kind of test here. And the outcomes, the complications from that unit are good, as in low complications, good outcomes. I would be content for a relative of mine to go and have surgery in that unit. What we have identified is that there is ongoing work for that team to do, and some of that has started. There's an external clinical director in, there's a load of other work outlined in the report. Risk is a very dynamic thing, and I think the important thing here is that the organisation identifies the risk, and we've commented on it in our report, but but it's what happens to that identification of risk that's the important bit. And I guess what we're recommending is ongoing oversight, monitoring, reporting of the impact of the interventions that the Trust is taking for that risk that we've identified and the efficacy of those going forward. So the risk is the identification of the risk is the important bit, and what they do next and the recommendations we have made, I think, are the things that will make the difference going forward.
I'm still a wee bit confused. So I'm obviously content, and I think everybody would be content that in terms of patient safety, you're saying there is no risk. You would be content that there's no risk with patient safety, but I'm still a bit...
No, I'm not saying there's no risk. I mean, every healthcare organisation has inherent risk, of course.
Okay. Sorry, let me rephrase that. Because I'm just going because I've read this phrase in your report, absolutely. And your report is saying there is still significant risk associated with the dysfunctional team dynamics within the cardiac surgery. So I'm just a wee bit unclear what that risk is and who is being risked.
So I think it's a really legitimate question, and it's something that we have wrestled with. It's important to make a distinction between the risks that we're identifying and the risks that previously were identified by the DCO Partners report. So that report identified issues about specific behaviours. And the Trust has worked, I think, very hard at challenging some of those behaviours, and it's put in place some measures. And that's laudable, that's fine. What we have found is that behind that, there are really profound relationship issues in that team, and that those are not going to be fixed easily overnight or by sending people through some training. And so when we talk about ongoing risk, it is not that risk is crystallised. It's not that relationships have now broken down, that everybody's fighting with each other and patients are suffering. It is that as we look forward, if that is not dealt with robustly by the Trust, that will inevitably have an impact on patient care and on the quality of service that is provided and on the stability of that service. So when we're looking at a risk, we're thinking, what are the things that might impact this in the future? And what are the things that could go badly wrong? And this is one of them. And that's why I think we are very pleased that the Trust has done what it's done in terms of bringing an external clinical director in, who is on the ground. He is a very eminent cardiac surgeon himself. He comes from outside of this jurisdiction, so he's got a clean set of hands, if you like. And he's coming in with a very clear mandate to analyse, to understand the dynamics of what's going on, but also to bring a fresh set of eyes to this. So the risk going forward would be that breakdown of relationships had an impact on care. At the minute, we don't believe it is, but that risk going forward, if it's not dealt with, will ultimately crystallise, and that's what we're saying.
And essentially, I mean, that was my question about the length of time that people, ministers, civil servants, permanent secretaries, trust chief executives have been aware of the ongoing situation, and yet, you know, even after this report, you're saying there's somebody external coming in to try and, you know, if I remember the public as I am, but I'm also the chair of the health committee, so I'm sitting here concerned that despite all of that we have not solved those relationship problems within the Belfast cardiac unit.
So I think that when you read our report, you hear that we are saying that we are saying that. Well, let me put it like this: Belfast is a large, complex organisation. There are always going to be behaviours that are challenging. The same would be true in any trust, I believe. What we are critical of in the past has been the way that the Trust has or has not dealt with those, and I think that's a very clear criticism coming through in what we're saying. We believe things have changed positively in the last recent past. So I think in the last year there have been seeds of hope. But you know, we mentioned in the report specifically issues of legacy. This goes back a long time, and I think that with Jennifer, I know, is sitting behind me, with a new chief executive, with a fresh wind, there's a possibility of change. But committee, I mean, I think we'd be very clear with you. This is not going to happen quickly or easily, because staff, frankly, are cynical and don't have a lot of faith in the system, or haven't had a lot of faith in the system. And what they're starting to get is a glimmer of hope now. But I think that needs to crystallise over time. So I don't think what you're saying is wrong, Chair. But I think that this is a complicated issue and it's going to take time to resolve.
Okay. And obviously your work initiated because of the problems within the cardiac surgery unit, but you were asked to look beyond that across the Trust. And when I was reading the report, I mean, it almost looked to me like, you know, because you're not saying there isn't issues, you're identifying issues, but you're trying hard not to identify them for us and maybe the public, and maybe there's a good reason behind that. But you know, I think we would like a wee bit more detail about cultural behaviour issues beyond the cardiac unit. You know, how serious are they? What are the risks involved, and what is being done to address those as well?
If I start.
Yeah, have to.
So I think we have wrestled with this. So what you see is a very intentional position that we've taken.
Okay.
We have heard stories from staff, testimonies from staff of other behaviours that are very concerning. And in each of those, you know, and there are a number of those around the trust, it is, I think, very difficult for us to judge whether that is unusual for the Belfast Trust compared, for example, to other trusts, because we don't have that data, and therefore it would be unfair of us to pick on that as a kind of a specific issue. What we sought significant assurance about, and I promise you we did this really robustly. There are none of the other areas that we were concerned about that the Trust is not aware of, and that there are not active interventions already involved with. And when we made the decision not to name them, it was partly because we didn't quite know where we would draw a line, you know, what would get in and what would the threshold be, and it just felt unfair. It felt unfair to the Trust, it felt unfair to the public to raise concerns that were not necessarily fully able to be crystallised. And what we did was we sought assurance from the Trust about the interventions that they are making, and sought, as you will see in the recommendations, very clear assurance that there was visibility within the Trust about those areas. You may want to speak to the colleagues following us about that, but from our point of view, we felt our job was to reassure ourselves that those are under control. Jennifer?
Yes, I mean, I would reiterate what you said. I think in any large organisation like this, there are going to be teams that have difficult interpersonal relationships. It's how the Trust manages and deals with those and supports staff. And I think our recommendations are trying to say, as these happen going forwards, teams are dysfunctional, individuals behave less well than expected, are the managers and teams equipped both with understanding of processes and the skill set to deal with those, to nip them in the bud before they become a major issue and a problem, and deal with them. And as I say, the areas where we heard repeated narratives, we sense checked with the leadership team that they were aware, and all of them they were. So we didn't think it was constructive to start picking those out. It didn't seem a helpful way to go.
So in your report, I mean, you helpfully give a lot of data in terms of procedures, processes, investigations, inquiries, etc. But you know, I couldn't find anywhere, and I didn't see any, where there's no detail of anybody or numbers of people who may or may not have been disciplined. So, I mean, some of the behaviours that we have heard, I mean, I accept it's also contained in your report that within the cardiac unit there's a dispute about the veracity of the report and all of that. But, I mean, we have spent a long time dealing with this because there's cultural and behaviour issues. You're saying now that they aren't just within the cardiac unit, they're beyond that. So, I mean, I would imagine in any organisation where people are bullying, where there's bad behaviour, where there's a toxic atmosphere, you know, any HR process, at some point people are disciplined. You know, is there any examples of people being disciplined within the Belfast Trust for bad behaviour?
This is another excellent question, and let me unpick for you some of the challenges behind this. So we sought data on this, and what we wanted to do was to find a way of us benchmarking data for the Belfast Trust, for example, with other trusts. And there's some of that in there, but what we ended up discovering was, and this is part of the paradox of this, if you have an organisation, as you do, I believe, with the Belfast Trust, where people have no faith in raising concerns, or very little faith in raising concerns, the levels of raising concern become low. People don't do it because they don't believe it's going to have an outcome. So getting overly fixated on what the data is telling us will give a skewed result on that, and that was the rabbit hole that we found ourselves going down a bit. So what we tried to do was focus much more on creating finding the narrative that allowed us to explain why, in a way, the disparity between what we were seeing, which was actually the Belfast Trust is largely in line with other trusts in terms of numbers of grievances raised and whistleblowing and that sort of thing. In fact, it's better than some. With what we were hearing, which was very little trust in these processes and people not necessarily believing that they're going to be listened to, treated properly, or that it will be acted upon. And the conclusion that we came to is what I've just described to you, that where there are low levels of trust, people just say, well, what's the point? There's no point in me raising that. They're not going to do anything anyway. And when we talk about legacy, that is one of the biggest challenges that the new leadership have to face. In terms of credibility, they are going to have to establish, and I'm sure you've seen Jennifer's video. I think it's superb as CEO, the tone that she has set for the start of her career and in response to this. But the key bit in that is saying to staff, we recognise that harm has been caused, we recognise that you've been hurt, that we haven't done things well in the past. We're now going to fix that, but this is going to take time. And there is a process that's required. I'm facetiously a little bit say a bit like Northern Ireland, where we have to deal with the past as well as sort of engaging with the future. And it is exactly the same for the Belfast Trust. There is remedial, restorative work that is required alongside then the transformation work to deal with the pain that has been caused.
Okay, and I mean the issue of confidence in the whistleblowing or staff going forward, I mean that shone through the report, and it was pretty shocking in terms of the levels of staff confidence, and that I'm not going to deal with that. I'm pretty sure others will probe on that issue. But following on from that and some of the other things in your report, because it was mentioned in your report and other officials at different times in front of the committee have previously commented on the size of the Belfast Trust as an organisation and the challenge that does. So, I mean, this is a question I will ask in the next session, but I'm going to ask yourselves, given the size of the Belfast Trust, do you, both of you, believe that it's manageable, or that it remains manageable when it comes to like issues of poor staff behaviour, of governance, of procedure, of good human resources practices?
Yeah, so I worked in an organisation of not a dissimilar size. I think it's about how it's run and how the leaders are trained and the culture of the place. I think you're getting at, is it too big and therefore unmanageable? I don't believe it is. There are many other organisations considerably bigger outside of health that can do that. So I don't think size is the issue. I think it's about governance, processes and culture. Yeah.
And I agree with Jennifer on this. I think that what Belfast perhaps has not done as realised actually is the need for an organisation that has over 20,000 people. It needs to have a real priority around how it manages its staff. In one way, it's irrelevant if you have the right infrastructure to deal with it. I mean, I think the complexities in Belfast are less about its size and more about the scope of what it is trying to do in terms of it. It is both a general hospital and a regional centre for excellence, and et cetera, et cetera. And there's something about how that is managed and organised, certainly that is challenging. But the simple issue of scale is, I mean, there are lots of large organisations that are managed really effectively, and there's no reason why Belfast couldn't be one of those. Okay,
and I mean, you have made a good few recommendations in regard to that. So my last question is, you've handed this report to the Minister. I mean, everybody's aware of it. The report is now public. So, what happens to your recommendations? Can the Belfast Trust pick and choose? They have to implement every one of those recommendations.
Well, it's over to the Belfast Trust now, and in a way, it's not for us to answer this. Our recommendations, we made them because we want the Belfast Trust to do that. We haven't made them gratuitously, and we've thought very carefully about them. So I suppose if I was being really honest, I'd be really disappointed if the Belfast Trust didn't. Okay. I do think there's something in this which is about understanding that this is a long game now. This is not going to be fixed easily or quickly. And when we talk about culture change, we're talking about years. And again, I go back to this issue of winning hearts and minds, that there's a really important process in this, which is about getting staff confidence back, that they are being well led and well managed, and that they will be safe enough going forward to raise concerns, and the organisation is genuinely interested. I mean, I've been quoted extensively around the being open stuff that I've done in saying that it's immoral for an organisation to ask people to speak up if it's not prepared to listen. And I think the Belfast Trust has been in that position for a while, and that really needs to change.
Yeah. And just And one more follow-up. Have you been asked, or will you be asked or tasked with doing any follow-up work with regard to the recommendations by the Minister?
There's been a suggestion that we are part of the process that may happen at some point in the future where a decision will be made to de-escalate from level 5, and I think we're both very open to a conversation around that, and I think that would be a very sensible thing to do. We've invested heavily in doing this. I think both of us are passionate about the possibility of change, and so I think we'd both be very pleased to be involved if we were invited.
Okay, and I probably should have said this at the beginning, but before I hand on to other members, I mean, it's clear in your report, big organisation, 20,000 staff. What we're talking about here isn't necessarily representative of 20,000 staff, so these are very important issues. Poor culture, poor behaviour needs addressed, but for a lot of people who work in the Belfast Trust, their experiences of work and patient outcomes and all is positive.
I think that's a really important point to emphasise, but I would say I wouldn't be overly dismissive of the numbers. This is not like a general survey. So when we sent out that original survey, we asked people specifically who had experience of raising concerns to respond to it. And that's why we say in the report, the people that we spoke to are the experts by experience of what it is like to raise concerns in the Belfast Trust. Arguably, they could be 100% of the people who've tried to raise concerns. So that's why I think the data is valid. For what it is. This is not a representative survey for the whole trust. This is very focused on the people who've tried to raise concerns and what their experience has been. And that's what we have, with I hope, integrity and vigour, tried to communicate to you in the report.
And then if I just add to that, the other thing I think is really noticeable is that even as people have been telling us unfortunate stories of how they feel they've been treated when they've raised concerns, they have equally at the same time been saying, and we want it to be better and we want to be part of it. So it feels like a group who are hurt in inverted commas, but also really keen to be part of the solution, which feels like a very positive position to be in, committed. Albeit it's sad that they've gone through it.
Yeah. Thank you. Just going to ask other members, and now Dan.
Yes, thank you, Chair. And can I echo, because I do think it is important to do that. Every day we are thankful for those staff who turn up, who save lives, and who, I suppose, look after us when we're at our most vulnerable. So it is really, really important to say that. And to thank you for the report. It certainly is an extensive report. And I think that there are some things in it that are very concerning. And the Chair has dealt with the issue of your view of potential risk in relation to the cardiac surgical unit, so I'm not going to focus on that today. But I am going to focus on culture and perhaps some of the issues around managerial issues versus the board, and how things may or may not have fallen by the wayside in relation to that. So I suppose my first thing is that when I read this report, and I read a sentence in your report, and you say, when asked to describe the nature of concerns that they raised, the main themes respondents described were of bullying, harassment, a toxic working environment, the misuse of power and processes, unprofessional conduct and disregard for policies, and patient and staff safety risks being ignored. That's damning.
And that is the truth. That's what we heard. And it was a very difficult process to listen to that and to try to make some sense of those experiences.
So having said all that, and I've actually read this report through twice, 2 or 3 times now, to try to get a handle on all of the themes in it, because I think there is a mine of information in it. So having said all that, what I don't find in this report is a sense of accountability and responsibility for this really toxic environment that you describe. I mean, you're describing bullying and harassment, toxic working environment, the misuse of power, unprofessional conduct and disregard for policies, and patient safety and staff and risks being ignored. But you don't address the issue of accountability and responsibility for that. Because I think, sorry, just to say, I do think that there is an appetite to move forward, but I don't think we can move forward until we address the issue of accountability. And to be honest, Peter, I find this in a range of issues to do with health. We run away from accountability.
So this was difficult, and so let me be clear about how we understood this. This is the situation where we were talking to a select number of people. So the people who talked to us were the people who had those experiences. There were 17,000 people who didn't talk to us. And I don't know whether we can argue that those 17,000 people didn't have those experiences. I don't know. I'm not sure we can go that far. I think that what we were resistant to doing was drawing generalized conclusions about a whole culture from those specific examples that people were giving us. What we felt confident about doing was saying, these experiences were very real. They exist in this organisation. We assume that actually they exist in most organisations. What we were prepared to say from a cultural point of view was that the organisation was failing culturally in its response to those behaviours. Because all of you will have had experience of large organisations. There's bullying in large organisations. These behaviours exist. Unfortunately, it's human nature. I'm not sure we were in a position to say that they exist any more or less in the Belfast Trust than anywhere else. But what we were prepared to say was that from our experience, the Belfast Trust had failed to respond to those as adequately as we would have hoped they would. And I hope you can hear the nuance in what I'm saying and what we're wrestling with here. I mean, the Belfast Trust is, there are lots of people in the Belfast Trust who have not experienced bullying, whose work, as you will well know, have never experienced any of this. So what we're focusing on, the intelligence that we're getting, is from the people who've been right at the pointy end of it, what their experience has been experiencing these horrible things, and how the Trust has responded. And our view is that in many of those cases, the Trust has responded poorly, and that needs to improve.
And who's responsible? So, because you describe an organisation that managerially is bloated, with little accountability from managers, nobody knows who's doing what, and who's responsible. Who is responsible for this damning situation that you describe in your report? Because unless we address these responsibilities and accountability, we won't know how to proceed or move forward.
I think.
Oh, go on.
Well, I was going to say, I think that there's a constructive way of talking about this, which is about accountability, responsibility, and then going forward. Yeah. So from a corporate point of view, the organisation is corporately responsible. The board is responsible for the activities within the organisation. That's true. I think that now that it's clear, what you as an accountability committee could expect is a very robust response from the Belfast Trust about what they're now going to do about this. I think that that's different to, for example, the question of who's to blame, because that's much more problematic. This is a systemic cultural problem that is it's very hard to pin this down to a single thing or a single set of people or a single level of management. It's in one way it's quite pernicious and difficult because of that. So it's very hard to allocate individual responsibility, certainly. I think that what I would want, if I were in your shoes, what I'd be wanting to hear is that the organisation was accepting responsibility for this and moving forward with a robust plan to deal with it and not denying it. And that's the bit that I think is most challenging.
Can I move on to the issue of that you talk about, because you have sort of cordoned off some issues into legacy issues, which is a polite way of saying these are very difficult and we don't know how to deal with them, in my view. And I think maybe in your view as well. So I have spoken to a very large range of mainly consultants, eminent people in Northern Ireland, who describe, as you say, a punitive culture, who describe the impact that it has had on their family and on their mental well-being, who feel that they have been punished for raising concerns and thrown into a process known as managing high professional standards because of it. those people are, I would say, at a fairly low ebb, and deserve something more from this report and from the trust than to lump them together into legacy issues, just my view. So these legacy issues and the issue of managing high professional standards. So conclusion 13 of the previous report actually says bullying can take many forms, but we heard firsthand that soft approvals, notification about leave, study leave, etc., were weaponised, often delayed to the last minute or withdrawn with little warning. It may be that this is more widespread, and we are concerned it might extend to MHPS professional reviews being used as punishment. Was that your experience?
So I think, back to your legacy point, we were very clearly told about the past and how the past was weaponisation of MHPS. But equally, from the large number of clinicians, consultants and clinical directors and above chairs that I and we spoke to, there was very definitely a narrative about punitive is being moved or has been replaced by supportive. And the numbers of people involved in MHPS processes are in the report and incredibly low. So I agree with you about the legacy issue, and I don't know that so much as too difficult to deal with. So I think, as Peter says, I think it absolutely has to be acknowledged the hurt that those individuals feel about what went in the past. But there was very clearly a narrative from many consultants that was not how they now perceived the approach from the medical director's team, and that things had changed.
But of course, Jennifer, for some consultants, things are irreparable.
Yeah.
So I
It is
completely get that.
actually
And I suppose
too late.
So I think that's
They are
exactly
irreparable.
the point.
I have spoken to people who have left the Belfast Trust.
Yeah.
I've spoken to people who no longer practice in Northern Ireland because of this situation in the Belfast Trust. It took me quite a while to process some of this information. It is appalling, but it's not legacy, because your report on page 13 shows that there is a steady increase in legal claims against the Trust over the past year because of these issues. So the Trust are going to pay, and of course I will ask Jennifer who is paying and where the money's coming from, but the Trust is continuing to pay, continuing to fight legal cases in employment tribunals on this very point. So it can't be cordoned off. It has to be dealt with.
So there's no implication at all in talking about it as a legacy issue about cordoning it off, I promise you. And I also would say that we have spoken to many of the people that you will have spoken to. I spoke to a number of retired, particularly consultants, who told me exactly what they've told you, and whose lives have been deeply damaged by their experience. So I think that we were very cognizant of that. I think the Trust there is a change in direction, but as with other points, this is going to take time. The fact that we describe it as legacy is because I think it is something that there is a sense of it is not the same now as it was then, and what is going to take some time is to work through what the repercussions of the past will be. So I would argue that those issues around litigation, etc., are to do with the time it takes to work through some of the consequences of issues that happened last year, the year before, 2 or 3 years ago. These things take a disproportionate amount of time, and one of the big criticisms around MHPS was actually the length of time that these things took. So I'm not disagreeing with you at all. I think this is an intractable, a vexatious problem. It is a difficult problem. There is no implication at all, certainly no intention on our part that this was somehow packeting this away to be forgotten about. It was more that it needs attention. There needs to be a specific attention given to how do you deal with this in order to free the organisation up to move forward. That was the intention of calling it legacy.
There's a big piece of work that's actually missing from this report that actually will tell us really in clear terms exactly what happened, why it happened, why MHPS was used in this way. And I'm not saying it. The first report that we received actually says it as well. Why it was used in this way, and why some clinicians I think are hurt beyond repair. And I think that that's just a fact. And I was disappointed, Peter. I'm being honest. I was disappointed that the report did not address what is a very, very fundamental issue, and an issue that won't go away, that will continue to cost the trust financially, and that there is no accountability in the report on this particular issue. Can I just ask one last question around structure? I mean, the report does describe a managerial system that seems to me a little bit chaotic, with very little sort of cognizance of who does what and so on. And in that situation, I think it's easy for stuff to get lost. And everybody who knows me knows I'm not a big process person, but process is important when you're managing an organisation of 22,000 people. And, you know, when you report figures of almost a fifth of that organisation reporting to you that they have no confidence in management, that's lethal stuff. That is lethal stuff. So really what I want to know is, and you will understand that I have spent a long time looking at how on earth we have a maternity hospital at £100 million or thereabouts that can't be opened because it's unsafe, and that the management actually took the handover of such a maternity hospital. So the kind of chaos you describe between management and board structures, is it possible that these kind of things can get lost in the telling?
I suppose I think that was probably more of an emphasis of my work, and I don't think I would have described it as chaos. I think what I was trying to do, and I think, reflecting on why maybe there's some recommendations being made about the board and particularly the board committees and the board structure. Yes. Many large teaching hospitals and institutions around the country have had a load of stuff to deal with, haven't they, in the last 5 years? They had a pandemic, massive waiting lists, change of senior staff in this organisation particularly, and then some other significant inquiries related to the Belfast Trust. So they've had a lot of things to deal with day to day. And I worked in an organisation where we had to absolutely, after a visit by our regulator and a very significant inspection, look very hard at our committee structure and spend some time with the board committee structure looking at the reporting. So we weren't in chaos, but it needed some work. I wouldn't describe it as chaos. I think the reporting, the wealth of governance data and quality data that the organisation produces could be more streamlined to make it easier for the board to see the wheat from the chaff, and how data that's analysed in a way that makes it easier for them to see the key priorities. But I wouldn't describe it as chaos. I think there are ways it could be significantly improved, but I wouldn't describe it as chaos.
I'll leave that point because I do think you and I will disagree on that. Okay. It is overly burdened with managerial process without people being clear, and your report says that, words to that effect, without being clear about who does what. In terms of board papers, every now and then I look up the board papers for the trust, and I think the last ones that were on the website are a long time ago, and they're incomprehensible. How on earth are board members who receive a huge amount of information meant to disseminate that and work with that?
Well, there are some recommendations in the report about precisely that, aren't there? Yeah.
I think we're asking people to deal with stuff, and I do suspect that that's how we've arrived in the position in many of these things that we've arrived at. Thank you very much, Chair. Sorry.
I think in the report it said by October. The last one was January of that year, so I mean that's quite a gap. 25. That's a bad gap.
For my sins, I do look them up every now and then to see if anything has changed.
I've read this one twice, then you must be.
Thank you, Chair, and apologies that I had to step out. I did check that you haven't answered this while I was out, but I just want to get an understanding of, and you kind of answered this a wee bit, Peter, but how can we be assured? So how are we going to ensure that the outcomes of the recommendations are measured? So I know you're saying the trust will decide whether they accept the recommendations or not, and we have the new chief executive in front of us. Now, I imagine that will be a question that she will definitely be asked as to whether she's going to accept the recommendations. But I'm on the policing board, and when recommendations come out of a report to PSNI, we'll bring them in front of the board or in front of one of the board committees, and we'll say, you know, which recommendations are you accepting? If you're not accepting recommendations, why not? You know, and those recommendations that you are accepting, how do you plan to implement them? And we will measure that. You know, they will have to report back to us on a regular basis. So is there some kind of mechanism through which, or is that something that still has to be established based on the Trust's acceptance or not of the recommendations?
My understanding is the Trust are accepting of the recommendations, but again, I don't want to speak from Jennifer will speak very clearly, I'm sure, on her own part. I think it is wholly reasonable to expect that the Trust will present to you at some point or a response to this, which is a detailed plan about how they expect to implement it. That's certainly what I would expect. That would be normal. I mean, I've been involved with hyponatremia and with neurology. Whenever recommendations are made, there is normally a response plan that is in place. And I think as a committee, it would be very reasonable for you to expect to have sight of that, to give yourselves assurance that it's not just a token exercise and that there's some detail behind what the outcomes look like. We have recommended a people plan, a 5-year people plan, and I would certainly, you know, from my own perspective, I'd very much like to see how that process is going to take place and what the measurables will be in that, because intrinsic to that should be that staff are engaged in that process and staff have a sense of ownership of that and are able to participate in what the metrics for success will look like. So
I suppose for me, measurable outcomes are the absolute, you know, the most important thing that we do going forward, because for me it now is about the future. Now I'm going to go back a wee bit to the past, but it's about the future. Okay. So, and I know, Peter, this is something that you've been before on and discussed with us around candour, and like one of the biggest issues here was either the inability to be, you know, to be candid, or I don't know what the reasons were behind why staff could not be candid about what was going on, about what was happening, didn't feel they had somewhere to go, or if they went somewhere, then that next level was not being candid. So for me, the question is, why did we not know more about this sooner? Because if there had been candour, we would have and should have and could have. And going forward then, is candour not what we need now to ensure that duty of candour? Because I accept what you're saying, and the ministers previously said that there was no risk to the safety of patients due to this, and you're saying that yes, whilst there's risk going forward, it's no greater than the risk in any other cardiac unit. So I'll accept that, but I am still nervous for families out there who have people that they love who are going on to this unit to be. I'm also worried about the staff. So how do we improve that going forward? How do we ensure that candour is at the heart of every single one of our units and every single part of our trust?
I share your concern, and I think that it's reasonable to be a bit nervous. I think we're at a stage where there is further reassurance required, and there is a process that is going to take time and energy. So this is not a binary thing. It's not that it was terrible and now it's fine, so we can all, you know, just take our eye off the ball and feel completely happy. There's a need for some concern, and there's a need for scrutiny, and there's a need for ongoing questioning of this, because it is not easily and quickly resolved. Mm-hmm. The issue of candour is really important, and I agree with you. I think that there is a need. My understanding of the direction of travel with this is that Northern Ireland will get a statutory duty of candour in the near future. But you know, I've maintained this all along. Just bringing in a statute isn't going to make a difference. It's culture. And if I could describe to you some of the stories that we have that might explain what you're saying. You know, if you're a person in an organisation where your manager has bullied you, and you want to raise a concern, but the person that you raise it to is best mates with your manager, so you don't feel that you can do it to them. So you maybe try and raise it to the person above, and they ignore you or tell you, "Never, don't worry about that. That's just banter. It's whatever." And that's the story that we heard multiple times. Then what that creates is a culture in which people have no trust or faith in raising concerns. So that's why you haven't heard about it. people, I mean, what we experienced were a number of people. There's an interesting consequence I want to say to you about the issue about the cardiac surgery report. There were people who spoke to us and where we said, why have you come forward now? Why do you want to speak to us now? And they said, because when we saw what happened with cardiac surgery, we thought that's the first time we've seen somebody raise a concern and there be action taken. So we thought maybe we can speak now. And I was quite shocked when I heard that, because I thought that shows the depth of, I suppose, cynicism that there has been in the organisation around this up until now. And what Jennifer and I are both experiencing, I think, because of the timing of this is, I think this is changing. I think we're on the cusp of a change. But it now needs attention, it needs time, it needs support, it needs resource, because it's not going to be fixed quickly. And if it is cultural change, then it is going to have to be nurtured forward. And so that's why I think you haven't heard about it. I think it hasn't filtered up. It hasn't been a priority. I mean, there was no formal people report, as far as I understand it, to the board of the Belfast Trust. So there was no mechanism by which anybody was asking the question. I think that is now different. I think that is now fundamentally different. And going forward, those kind of metrics will become a source of significant interest to the board because of this. And that is, for me, hopeful. That is a hopeful sign.
I agree that there absolutely needs to be a cultural change, and I think the two things do go side by side. One cannot go without the other. But I mean, for me, I think this goes back to the first point, that the measurable outcomes, we need to see measurable outcomes, and that will be about, I think, going back and doing something similar to what you did in terms of staff, and getting an update then on how things have really changed on the ground. Thank you, Chair.
Earlier.
Thank you. Thanks very much to Peter and Jennifer. So, Peter, maybe if I could just ask to begin, it's maybe to bring it back to Diane's point around the accountability and responsibility following on from this report. So I know that you've been involved in this type of work for a good bit, and we welcome that. But was there a report or a presentation that was brought to the Department of Health around 2 years ago on some of these sort of similar issues?
If you're talking about the work that I did?
Yes,
yeah.
yes.
So let me, I'm happy to talk about that. A few years ago, I was commissioned to do a piece of work by the Department of Health on being open. And it was the start of a process to develop a framework, which is now, you may have seen, it's been in consultation, it's about to be finalised. Mm-hmm. And at that time, the Belfast Trust approached me and offered to be the first trust to engage with that. And that was the then Chief Executive had just come out of the neurology inquiry, and there was, to be fair to them, they recognised that they had an issue and they wanted my involvement in that. So in order to, and that was, so remember, the focus of that work was on being open. It was not an analysis of the Belfast Trust. It was no analysis of what was going on there. The purpose of that work was to get the intelligence that I needed to develop the being open framework. It involved a process that was not dissimilar to this one. I talked to a lot of staff. And in the course of speaking with staff, I heard similar things to what I've heard in this process. And that left me with a problem. I couldn't hear that stuff and not do something with it. And to be fair to the trust and to the Chief Executive and Chair at the time, I said what I was hearing, and they said, we think that you should present this as part of the story to the board, which I did. I presented it twice, and I presented, and the focus of that was not at all as comprehensive as what we've spoken about in this report. It was quite focused actually on probably the senior team and challenges in terms of the way the senior team was behaving and individuals in it were behaving with each other. Mm-hmm. That was not a formal report. It was a presentation to the board. I was very conscious that I had not been commissioned to write a report. I didn't want to step beyond my mandate. My mandate was from the department, not from the Belfast Trust. Mm-hmm. And my mandate from the department was not to write a report on the Belfast Trust or the senior leadership team. So yeah. I hope you can hear from what I'm saying. I was kind of slightly stuck between a rock and a hard place. Mm-hmm. But in terms of my own integrity, I fed back to the trust at the time mm-hmm. what I had heard and my view of what I had heard. And it was up to them then to respond to that whatever way they chose.
Okay, and just my reason for asking, because as I was reading through the report that you have just published, it's trying to get a sense of, even if you're going back to, if that was maybe 2+ years ago, at that stage, what was there any formal ministerial response, direction, Was there any formal procedure or response put in place by the senior trust management or the board of the Belfast Trust at that stage in relation to some of these issues that have obviously come up again 2 years on?
I think it was dealt with as a concern by the Belfast Trust. It did not escalate beyond the Belfast Trust. So again, it was not my job to report that back in through the departmental system. This was for the trust to deal with. And my understanding of it was that there was some action taken, some further work that was done. I wasn't privy to that. It was I offered my views on it, and then it had nothing more to do with me.
The Minister was aware of it?
The Minister was not aware of it.
He wasn't. Okay. And then I suppose it's going back to Linda's point as well. It's how, as a scrutiny committee, we can support the Department of Health, support the Trust in terms of next steps, accountability, outcomes, and all of the rest, because that's the place that we all want to get to for our health and social care staff first and foremost. And maybe then I'll move on to the issue of the HR, because I know that there was clearly significant challenges flagged in your report in terms of the HR function within the Trust. I think there was 19 references to it in the report overall. And I know that, Jennifer, you have mentioned, of course, the size and the complexity of the organisation that you're dealing with. And you had also said, Peter, which is true, of any type of organisation of this vast size, you have to expect, regrettably, that you will get instances of bullying and bad behaviour. But on the issue of the HR function within the Trust, do you have any assessment of, maybe why the sort of quality was failing in terms of people's complaints maybe being processed in the proper way? Do you have any sense of, I know there has been some changeover in staff with the HR and maybe even possibly a reduction in its size. So have you any assessment on what your viewpoint would be if the role of the HR service itself is maybe failing the Trust?
I start?
Yeah.
So let me start by saying in most organisations I've worked in, people complain about HR. They tend to want HR to do more than it's appropriate for it to do. So I do want to acknowledge that. In my view, I suppose, in the Belfast Trust, my expectation of the HR in any organisation is that they fundamentally are the custodians of the processes that we've described. So processes for raising concerns, whistleblowing, how staff are supported to speak up. Managers have a responsibility to action that, but in the organisation, HR are the custodians of that and should protect people's rights as employees. Whether you're a porter or a paediatrician, it should not matter. HR's job is to make sure that all staff have the same fundamental rights as employees and action that. So that's the starting point. I suppose in the Belfast Trust, I'm not sure the Trust itself, and if I talk about the corporate body, knew how to use HR. So I'm not blaming HR individuals in this at all. I think the organisation itself had not prioritised people, and therefore had not prioritised its HR function or supported its HR function to deliver on that. And that's just I suppose it's my view. I think there's probably an issue around resourcing. For a large organisation, I think there's possibly a question on, the amount of staff that are required. Mm-hmm. But I also think there's something about where it sits in the organisation in terms of priority. And I suppose it would have been my experience a few years ago, and it's my experience again now. It has not had the central priority that, in my view, it should have as an organisation where it has 20,000 staff who are arguably your key resource to deliver services. So, our recommendation is bring this front and centre. Make your people your priority. They deliver your services, support them, manage them, challenge them when they behave badly, protect them to raise concerns, but make them your priority and build your strategy around that. And that's that for I think going forward, that's what will shift this.
Okay, thank you very much. And that's something we can pick up with Jennifer as well in the next session. Just my last question is around, you have made a comment earlier, Peter, that if the issues that have been obviously raised, brought forward to yourselves, and the issues that are contained within this report, if these core themes aren't dealt with robustly by the Trust, that this will have an impact So when you say that, and then you're talking about, you know, in terms of how long it might take to fix some of this, that it's a long game, that it could take years. So we're talking about maybe a protracted process to try and, you know, fix some of these issues. But what would be your message after all your work on this report, yourself and Jennifer, when you talk about there might be an impact if this is not robustly dealt with? If you just maybe want to pass a wee comment to
So again, maybe if I go
expand on
first.
that.
Yeah.
So there are two things in this. The first thing I want to acknowledge is that people were very courageous in coming forward and speaking to us. And one of the responsibilities that Jennifer and I felt with this was how we honour the courage that they had in coming forward. Because these were people who were sticking at it. As Jennifer said, these are people who continue to love the Belfast Trust, love the work that they do, are very proud of the work they do and the outcomes they deliver, as well as having had these terrible experiences. So I suppose the first impact, if nothing is done about this, is that those people are let down. They've had the courage to speak up and nothing happens. And I would certainly feel that acutely. I feel a responsibility, having heard what I've heard, to make something different. I think that what the Trust needs to do now has already started. So if you see Jennifer Welsh's video response to this report, I think that it is pitch perfect in terms of the message to staff, which is to say we acknowledge that harm has been caused, we're now looking forward and we're going to work hard to fix this and we're going to involve you in it. And understanding that this is going to take time, what people need at the start of this is hope. They need to believe that somebody's going to listen to them and take it seriously and that there will be a difference. And so I do believe the Trust has a responsibility at this point to signal the way forward and say, we're taking this seriously and here is the direction of travel and here's where we're going. We have both received feedback in the last day or so from people we've spoken to. And I have to say that's the word that they've started to use. They said this gives us some hope that there is now a way forward, and I think that has to be a good thing. Thank you.
Nuala? Nuala?
Can you hear me okay?
Yep. Yep.
Hello. Sorry I can't be there in person. Thank you for the comments so far. I have a number of questions, and I'd just like to go back to the recommendations, and I think all of us on the committee would agree that not just the Belfast Trust, but a number of the trust areas, that there is an issue with whistleblowing in terms of how it's actually moved forward. But in 2018, Justice O'Hara did make 96 recommendations after the hypnotremia inquiry, and one of those actually included online mechanisms for whistleblowing. The department, in response to the committee today, has said that it considers the recommendations relating to this implemented, but this report has come out now 2025, and it's 7 years after those recommendations made, and it's quite clear that, you know, it's not working. It's just quite simply not working. But like, forgive me if I'm skeptical as to whether I believe that it will in fact change now, because there's too many other examples where staff do not feel that they can speak up, and those that do have counterclaims then made against them. What kind of assurance do you think can be given from both of your perspectives in the work that you have undertaken now that there is a change that is going to happen?
I'm not sure we can give an assurance. I think that our job has been to diagnose and to give a direction. I think the assurance that you're looking for needs to come from the people following us and from the department. I mean, if I speak specifically about whistleblowing, the problem with whistleblowing in the Belfast Trust was a huge amount of confusion about it. I think that people, having lost confidence in any other process to raise a concern, thought that their last resort was to be able to use whistleblowing. And so ended up at times using it inappropriately and then becoming frustrated and disappointed because it didn't do what they, didn't, for example, protect their anonymity, which they expected it to do. There are other alternatives that they could have had, but that some people didn't necessarily know about other prescribed organisations like the Ombudsman or RQIA that they could have whistleblown to, but that was not widely known. So there was a huge amount of, there was a lack of awareness of what their options were. The reason we have recommended an independent regional whistleblowing facility is not to undermine the necessity of the trust to get its act together around its own whistleblowing capacity, but because there is such a degree of cynicism and lack of trust around in the trust around this, that I think there is a need, even if it's in a temporary way, for there to be a visible independent regional capacity for that. And I think it is exactly the same around the regional freedom to speak up. It's the same principle. Arguably, this is what any good trust or any good manager should be doing on a daily basis. That's not where we are at the minute. There's no trust. There is very little confidence in the system. Therefore, we need something in the interim, maybe long term, that allows people confidence that there is a place that if they raise concerns, they can go to in extremis. And that's why we did that, Nuala. And so I can't give you assurance, as I sit here, that that's going to be done. I think that can only come from the department and from the trust itself.
And we'll certainly ask after. It is disheartening when you see inquiries years ago make recommendations and departments say that they're done, but actually the same issues just arise. I know that you've said about legacy issues, but actually it's still really important for transparency and accountability to ask questions regarding that. There was 18 months, roughly an 18-month period from when some of the initial complaints were first raised until I believe maybe October to December 2023-24, where it seemed that relations and the whole atmosphere was different within the cardiac unit. And then it seems to have gone down or been frayed again. Do you think that risk that you speak about, and I know you said you can't really quantify it exactly, and we all understand that, but do you think because of the way relationships are at the minute that there's a risk of even more people leaving? And do you think it can continue the way it is, or that there needs to be personnel changes?
I think we spent a fair bit of time with the surgeons, meeting each of them and the rest of the team. I think any team disquiet or disharmony will always lead a clinician to consider whether there's a team elsewhere that would be a happier place to work. So I think that is always a risk if you have a team that isn't happily working together. However, I think the trust, by both bringing in an external clinical director, as Peter said, a highly respected cardiac surgeon who they know of, shows the seriousness with which the trust has views the service and how important they are. And in fact, we met with the cardiac surgeons, with the chair and the interim chief executive, and expressed exactly that. So I think my sense from that is that they know that the service is valued and they're cared about as a team. And I think that, plus the surround work that's being done, I think is the best the trust can do. There is a risk individuals could move on, but I think we have to invest the time and energy, and the trust has to invest the time and energy in trying to keep that team together and have a service for the future for Northern Ireland.
And what happens then if we have people who are not the lead or not the consultant surgeons, but they are training and hopefully can step into the shoes of those who maybe had decided to retire or move on? What happens if we do have, because this is a regional service, what happens if we have even a small number of individuals who are being trained for the future do leave, either to the Republic or across the water?
I mean, I think it's very hard to answer the question of what you do if you're short of personnel. It's a very small, there are only 300 cardiac surgeons in the UK. There aren't a lot of them. It's a pretty small specialty, but it's a highly regarded unit. I would be very hopeful for your future of recruitment. But yes, it is a risk, and that's exactly why time and energy is being spent trying to improve that team dynamic.
And I just want to ask on the maintaining high professional standards, and I know that some of it's mentioned in the report, but it's not very detailed. But I wonder if you'd be able to elaborate on regarding how many complaints or even counter complaints were made regarding the issue of maintaining um, high professional standards. Because my understanding is that a large volume of complaints were counter complaints. And are you aware of whether many or any of those have been dismissed?
So, don't know the details of individual cases. We provided you with in the report with the details of the ongoing cases, and as we said in the report, a number of years ago there were a very large number of open files which were concerns about doctor rather than doctors necessarily in MHPS. But we don't have that level of granular detail that you're asking for.
Okay, but that strikes me as something that perhaps should have been looked into, is the level of power that people have to use the current process to silence. I think it's very important, because if we don't look into those issues as well and change all of them, then others might also do the same in the future. Do you think that this is something that the trust board and management themselves will be looking into? I'll ask them again
I think
after, but can you understand where I'm coming from? If there are concerns that we're not looking at the tools that people have to make counterclaims in order to absolve themselves of responsibility.
I think we have been very aware of that particular dynamic, and that was the big criticism. The phrase that's been thrown around about MHPS historically was that it was weaponized, and that's what people were talking about. If you raised a concern about me, then I would raise a counter one about you. I think that both Jennifer and I are quite reassured that that culture, that single component of this culture, is no longer the case. And that would be based on the testimony of a number of the senior consultants that we've spoken to. That's not to dismiss Diane's point, which is that there is a very significant lack of trust because of the way that this was handled before. But I do think that there's lots of evidence in the last year, empirical as well as anecdotal evidence, that shows that there has been a shift in how that's being used. But I think it's a very important question to keep asking, because the way that you're describing it is exactly the way that the harm was being done. It was felt to be an abuse of power or a misuse of power, and I think that's a very important question to keep asking.
And I just want to have more questions around the whistleblowing process in terms of were you made during the process that you had with all the individuals involved? Were you aware or concerned at all about managers, regardless of what structure they sit under, clinical, HR, etc. But from that area, were under scrutiny that then played a role in the actual whistleblowing investigations or process? Because it's something that arises time and again following inquiries that we have, whether it's about Dr. Watt or the hyponatremia inquiry, is that the people that we expect to actually implement change are some of the very people who actually have been involved at management level in the issues in the first instance. And are we seeing that in this?
Yes, I think we are. And that's what some people told us, that their experience of whistleblowing was they would raise a concern, and the very people who were dealing with the concerns were the ones that they had the concerns about. And it reflects in this regard, I'll use the word chaotic. I think there has been a chaotic feeling around whistleblowing and how it's been understood and how it's been managed. And remember, that's not just the responsibility of those who have whistleblowing in their title. That's about how ordinary managers manage it. So I think you're right, Nuala, and it's one of the reasons why I think, alongside the trust itself, paying attention and improving its internal communications and clarity around how it manages whistleblowing, there is a need also for people to have reassurance that if they don't trust that and if they're not satisfied with that there are other remedies that they can take so that they don't feel trapped or powerless. That if they are not satisfied or they don't feel confident about using mechanisms the trust have, they need to know that there are other credible mechanisms that they can use that will support them to do it.
She's frozen there.
I think so.
Individuals involved, and is really, and I know Diane mentioned it as well. One thing that's really kind of missing from the report is that accountability of individuals involved. And surely, if you don't have that, then how can people have confidence that any system is going to bring about change and people will just continue to get away with it, issue after issue. Like, we see it all the time. We don't just see it in health, but we see it in health a lot more. And if we don't have that individual accountability as well as organisational accountability, then what is actually going to change? Who ultimately is held accountable? How many of, like, I'm not saying name people, but I mean, I honestly, I believe that Ciara Mulgrew was a sacrificial lamb when it came to this issue. And reading this report, I do not understand why it seems that he is the person who has been held responsible when there are people who've had their hands all over this, and it happens time and again. What is it going to take for something to change?
Not really.
I don't know if you want to comment on that.
I mean, our hope is that this report will precipitate change.
Yeah.
And that's why we committed to it, and that's why we've written it. And we believe certainly that if the actions that we recommend in this are taken, then it will make a difference. But there's a big if in there, and it requires the trust and the department to take responsibility and to move forward with it. And that is our aspiration.
Yeah.
Okay, no,
Look, thank you. Yeah, I have more questions for the trust after, but it's disappointing that we don't get to actually ask questions of people who would have been involved, even higher up the chain of command during this 6-7 year period.
okay, thank you, Neil. Alan?
Thanks, Chair. Thanks, Peter and Jennifer. Your opening line, Peter, you had made reference to the numbers of staff that had come forward, some of them on the back of communications that they had with us, who we subsequently encouraged to speak to yourselves. Obviously, during those conversations that you had, you will have obviously spoke to a broad spectrum of people who have made comments about a broad spectrum of people.
That's right.
How far up, without obviously detailing any rules, but how far up the health service chain were those allegations? Because, and I say that because on the back of one of the communications that I received from a surgeon, they alleged that an individual very senior in the health service used the term of being nasty and a bully. So has that been your experience of those people you spoke to, that it did not just transcend across, but it also went up?
I think it's fair to say that we experienced what we heard from people was a very broad cross-section of criticisms that went up and across the organisation, right to the top and across. So yeah, I mean, it was I think that because of the number of people that we spoke to, and it was, if I can tell you, there were times it was very frustrating because we had to be clear to people that we couldn't follow up on individual cases. It was not our job to follow through, despite sometimes hearing things that were very distressing. But we did hear a cross-section of criticisms that went both up and across the organisation.
Obviously, I had no communication with Diane prior to this, but she used the term which I had exactly written down, damning, and that is of page 15, 16 and 17. And that was, which covered the pages of feedback from staff. And I'll quote some of it. Feeling confident about reporting concern, 65% said no. Do you believe the Belfast Trust would treat concerns that you might raise with the appropriate confidentiality? 61% said no. And even worse still, did you report the behaviour you witnessed? Almost 80% said no. And the reasons: fear of retaliation and a belief that nothing would change. That is just stunning. And then it goes on again, worse still, when it talks about the main themes in terms of the nature of the concerns that they raised, one of which, patient and safety, staff safety risks being ignored. And then we have a health service who speaks frequently about the importance of mental health. And here we have, by way of consequences from those concerns that were raised, the consequences that they felt was mental health harm and suicidal thoughts. What was your thoughts on that?
I think that what that reflects is the moral trauma that people experience.
Absolutely.
And it also reflects, I think, what we've said a couple of times, which is in the Belfast Trust you have staff who are deeply committed to what they do. Okay. And they care about their patients deeply. And it is their life vocation to do this work. And there is a mixture of challenge with that because of the very clear pressure that the health service is under. This is not particular to the Belfast Trust, but the challenges that the health service faces, I would argue, we've used the word in here, impossible, and we stand over that. This is sometimes we are asking staff to do impossible things. And yet they turn up every day and they do it and they give of their time, and sometimes they give of their health to do that because they're so committed. So, I mean, I think the evidence speaks for itself. Now, do remember this was 17% of that population, so there are other people in the Trust who have not had those experiences, but we were targeting those who had these specific experiences of trying to raise concerns. And that's why I think this is such a, maybe it's stupid of me to say this, I think this is really important. It's really, the reason we've done this and the reason we've communicated to you in the way that we have is we believe it is really, really important. Because it's people's well-being, and ultimately there is a very clear link between the well-being of our staff and patient safety and the quality of outcomes. So, as an organisation, the Belfast Trust is a people organisation. It is people who deliver care. It's people who look after us when we need them, and it is the Trust's responsibility to look after those people.
Peter, some of the recommendations that are on the back pages here, a lot of them make reference to shoulds, and in our belief in here we would like to have seen must, and even I see even in the recommendation 7 you talk about the CEO should review and consider reduction in size of the executive team. Consider. And what if they don't? What if they consider it and say we've considered it and we believe the bloated organisation that we are, we're going to remain as is? What's the fallback on that?
I think that this is, I suggest you speak to those coming behind us, because I do think there's a bit in this where we say, here's what we found and here's what we believe you need to do. Yeah. I think that arguably the experts in this are sitting behind us, and they will be the ones who will say how this can best be implemented, and you will indeed, I'm sure, hold them to account for how they choose to do that. We're all grown-ups in this room. We all have responsibilities. We've done our bit. Now the Trust need to step in and work out what this is going to look like in practice, and your job will be to hold them to account, among others, about how they do that. If we are all agreed that our joint purpose, with all the different roles that we have in this room, is to improve the health service, improve the care that people of Northern Ireland deserve, then we each need to work out how we step into the responsibility for that. And I think that's the big challenge that we all face. Jennifer?
Yeah, I think, you're absolutely right. I think where we've said should consider, it needs some nuance. It's not quite so clear cut. Some of them we've been a bit stronger because we feel quite a bit more strongly about it, but I think it is. I think would be for the Trust to say, the recommendation said you should, so there needs to be a jolly good reason why you wouldn't, and to explain that very clearly. But we've been as strong as we thought was appropriate for the individual recommendations.
Danny?
Thank you, Chair. One of the great things about going last is that all the questions you were going to ask have already been picked up by almost everybody else. I
can think of a few more.
Obviously, this comes from a very concerning, long period of bad behaviour, really unacceptable behaviour, and certainly when this came to light, there were huge concerns at this committee about what had been going on, and obviously your investigation has been instigated in order to take a deeper dive into that. I have a couple of questions. I want to go back to one of the first things. So there is an ongoing risk to service delivery and patient safety within the cardiac unit. What are the risks to patients and service delivery?
So I think as we tried and possibly didn't explain as well as we might have done at the beginning. So the individual patient risk today, and as I said, if my relative was going into that unit, I would feel safe and comfortable. However, we know that psychological safety in the workplace is what is required for a highly functioning team. So teams that trust each other, that have each other's backs, that want to innovate and develop will do so best if they have psychological safety. So to maximise that team going forward, that would be something that's very important to pay attention to. So there's a risk there because we know that there has been dysfunction in that team. We want it to be a highly functioning team, developing and progressing. That's what needs to improve for that to happen, would be how I would probably describe it.
Remains dysfunctional then?
I think there are still ongoing relationship difficulties between members of that team.
Okay.
But the interventions that are underway are to try and improve that situation, and our recommendation is clear that the Chief Executive and the Interim Clinical Director would keep a very close eye on that team going forward.
With previously, I think 7 patients had their operations postponed because of behaviours. Is that still a risk? Is it a risk that because of if there are continued dysfunctions within the team, more patients will have operations?
We've had absolutely no suggestion of any issues in that regard whilst we've been doing the work.
In your report, it does mention some cardiac surgeons questioned the validity of the original report. So it seems to me there's an attitude that this is not needed. We're okay, we're going to continue in that vein, and I know you've put in quite a bit of extra governance in and around that team. And there is the cardiac consultant who's now in post for 6 months, and there will be regular checks, I think at 3 months and 6 months at that time. Can you have confidence that, given this prevailing attitude that these investigations don't seem to be warranted, don't seem to be needed, that change is going to happen?
I think to explain that probably a little more, I think the toxic culture that was described in that report, some of the surgeons didn't recognise it because they didn't see it in their practice, they hadn't witnessed it, so it was more the way the unit was described externally felt unfair from their perspective. They were very concerned at the impact on the wider team from the description, and in their experience in their theatre, on their ward rounds, in their clinics, they didn't see the behaviour that was described, so it was more that than we don't have a problem. They hadn't personally experienced it and saw that the nursing staff and others had felt quite hurt by the way the culture had been described. So I think it was more that's what we were getting at or describing.
Okay. Some of the original patterns in the original report were about bullying, particularly of junior nurses, and many of the junior nurses would have been female and from overseas. Was there any sort of trends that you picked up in your investigation about levels of bullying or females, particularly young females and overseas workers?
Do you want to start? No, so no would be my answer, but do you want to extrapolate?
I spoke with a couple of people who were not from Northern Ireland, where coming from overseas was an added dimension to their anxiety about raising concerns. So for people from overseas who maybe had visa restrictions, they had an added anxiety that if they raised concerns about what they saw, that would affect their employment or their ability to stay here. And that was a very particular challenge that was not necessarily had crystallised. It was just an anxiety they carried with them. And I think I don't think that's news. I think we understand that it is one of the difficulties for people from overseas to feel that they can challenge. I think that's one of the cultural challenges that we face. And I think I'm fairly confident that the Trust does some work around that in terms of supporting staff that come from overseas around those cultural differences and the expectations raised challenges here. So I'm quite confident that that is understood and known, but I think it's an important issue, Danny.
Thank you. The Trust remains in level 5 intervention. Have you any feeling, and I know that you'd mentioned in one of your answers that you have been approached about at some point being involved in some other event where you would review how recommendations had been taken forward. Have you any view about how long that should remain in place, or when it should be reduced, or what the threshold for reducing that level of intervention would be?
No specifics. I mean, I think I assume what I assume what would be required is a convincing response, for example, to this, that everyone was satisfied there was a robust and credible response, and again giving staff hope for the way forward and giving the department confidence that these issues are now under control. I have no sense at all of the timing of that.
Yeah.
One of the figures that really struck me in your report was the 62% of people who reported seeing behaviours that should have been reported didn't report them, and 20% that did. You know, that's a very, very concerning issue. And
that's the link with patient safety. So when we talk to people, part of what we did was, having had this data, is then to talk to people. And when we would speak to people about this, why would you not raise a concern? And there's no point. Nothing will be done. I'll get punished if I do. So these things are all connected.
Yeah, and I think the proof of the pudding will be in the eating of people start to raise a concern, something's done, that's shared. That's that cultural shift to say, look, tell it. The stories need to be told about how raising concerns were welcomed. And actions were taken on the back of it. That's that message that needs to keep on going out, and I'm sure that'll be something the Trust's thinking about.
And as a metric, and I know we've talked about metrics of outcomes, will that continue to be measured? Is that something that we should look at, about people, as you say, feeling that they're listened to and that their concerns are being taken on board?
I think there's a lot of thought needs to go into this. In a weird way, if an organisation is showing low levels of people raising concerns, that is not necessarily a good thing, and that maybe is counterintuitive, where you think what we want to do is drive that down, when actually what we're saying is what we'd love to see in the Belfast Trust is that the level of raising concern goes up. But it would be awful if that happened and then they came to you for scrutiny and you challenged them on that. So there is a sophisticated conversation that needs to be had here about what success will look like, and it has to go beyond simple metrics. There has to be an understanding of the stories. I mean, Jennifer has just described it. What are the stories behind it? What are the examples that people can give? Because they give us examples at the minute that are very negative. My friend raised a concern and she ended up having to leave, and you've all heard those stories as well. What needs to happen over time now is that alternative stories start to come in of good experiences, and a sophisticated interpretation of the metrics. Where we see an increase in people raising concerns as a positive thing, especially if those are being positively resolved. And so I do think it's important, the questions that we ask will determine the answers that we get. So it's important to ask the right questions to make sure that we're getting the right answers.
No problem. Thank you. I know this report is just the start of change, and I do hope that there will be the recommendations, as you say, you're under the impression that they've been accepted, and that we as a committee can have scrutiny over how those recommendations are put in place and implemented, and that change is measured and this does become safe. And it will be over to the Trust now in order to do that and to rebuild that public trust within staff and within the public at large. Just one last question. This was started because of an incident within the Belfast Trust. I've heard from other people in other trusts who have concerns about that type of behaviour within their own trusts, and I absolutely would encourage them to go and whistleblow and raise those concerns and make sure that they don't walk away. The concerns are always raised and they're raised in the appropriate manner. Do you think there's another Belfast Trust? Do you think there's another cardiac unit out there?
It's an impossible question. If I could answer it slightly differently, I'm not a politician, but I'll try to not answer the question that you're asking. I think that there are lessons in this for the region, and I don't quite know the mechanism by which those would be learned. I think the Belfast Trust is not alone in the challenges it faces. I think it's unfair to kind of focus too much on it when some of these issues are clearly, I think, across the whole region, and there's the opportunity here for some learning across the region. It's why we made a couple of departmental recommendations on the premise that those would have a regional impact, and I think if there was some thought put into what the regional learning might be, that would be a very useful thing to do. I hope that's an answer. Thank you, Dan.
Thank you, Dan. Al?
Yeah, I have a very brief, Chair. Just, I think out there, particularly within the public and maybe even within this room, that there's perhaps a misunderstanding of what your terms of reference actually was, and maybe a higher expectation of what your report would actually come back and say. And just to clarify, you were sent in to identify the problems, but it wasn't your brief to fix them. You've suggested cures, but it will be others to take up the baton going forward. So I think that's important to clarify that in the public eye. But just, you've talked about it's going to be a long-term fix. And we know there's no magic wand. People are not going to start liking each other overnight. So it is a long-term project. But just, this may be a difficult question to answer, but if the Health Minister brought you back in a year and said, same terms of reference, go in, have a look, what would you expect in a year's time? What would you see as success? What achievements from within your report would you see as successes?
Jennifer, do you want to?
Yeah, I mean, there are some obvious ones, I guess, around, committee structure, reporting, some stuff around, reporting outcomes, reporting people metrics, so some measurable process things. The culture bit is the bit that is going to take longer, and so to expect a change in that in a year is probably a tall order. But I guess some of the stories we would want to see more flowers blooming around the place, saying, I can see more hope, more evidence that, there was an example in a trust I worked in previously where the medical student pointed out to the brain surgeon that he was about to do the wrong thing. The chief executive went and found the medical student and thanked them and said that was fantastic for having the courage to speak up. That's the kind of stories you would want to be being told. It's a rather extreme example, but that's the so I think shoots of hope alongside those rather procedural process things, I guess, what I would say.
And I would love to, in a year's time, I'd love to, in the Trust, meet people, ordinary members of staff who said, over the last year, I've been actively involved in helping the Trust devise its people strategy. And I've had a real influence in how that is influencing my bit of this organisation. And I can show you how that's going to improve my well-being. So I would love that sense of the Belfast Trust as a community taking ownership of this, and staff being facilitated to have their voice heard and being given agency to change things themselves, as well as the Trust doing what it needs to do. So it's this thing of just mobilising the talent that exists within the organisation at a grassroots level to help people take responsibility and ownership going forward. So I think there are things, Alan, after a year that you could see that are very doable. This is not going to be fixed in a year, but after a year, I would expect to see certain things in place that would be the signs of hope, those green shoots of hope for staff. And I suppose anecdotally, as we chat to people in the cafe or whatever, that they're telling us the stories that Jennifer has said. We had this problem, we raised it, our manager took it seriously, we made changes, we've learned from it, and now we're moving on.
Well, thank you very much for your piece of work. Obviously, a lot of time and effort went into it. Thank you.
Dan, allow Dan for a quick question and a quick answer.
Well, just first of all, to agree with you about the priority that should be given to HR. And in defence, you indicate that the whistleblowing manager operated on their own without any administration for a trust of 22,000 people. That seems to me an impossible task. So just to set that out. You talk about the issues that Alan talked about, and you describe them in some detail, and you give metrics around them about how the Trust responded to people and how people felt lack of confidence, and you described it as an abuse of power, it was an abuse of power. Was it maladministration?
I think it's really hard to define what the cause was, whether I think some of it was probably competence, confidence, ability. desire. I think it's really hard to diagnose.
A lot of what we heard, and this becomes anecdotal, but a lot of what we heard was people who would raise concerns and managers would apparently not know what to do, and or would actively do the wrong thing, and so proper processes were not followed. But there was no discipline around those processes, so the fact that they weren't followed wasn't picked up on. So it becomes a vicious circle of. So I don't know if you call that maladministration or not. That for me is about a culture in which there is not a discipline around following proper process in
We're
these
back
orders.
to my first point.
We are.
Accountability and responsibility and the lack thereof. And until we fix that, until somebody is accountable.
Okay, thank
We're
you.
going round in circles.
Thank you very much, both of you, for the report and for giving your time today and for answering our questions. Really appreciate that. So thank you very much.
Thank you for the opportunity. We appreciate it. Thank you.
Thank you.
Okay, members, item number 6 on our agenda, oral briefing from the Belfast Health and Social Care Trust. So can I refer members to our papers, tab 6, page 62 of the main pack. I'm going to welcome Jennifer. So, Jennifer Welsh, Chief Executive of the Belfast Trust. Is Tracey here?
Good afternoon.
And also Tracey McCaig, Chief Operating Officer within SPPG. So, you're both very welcome. And I'm going to hand over. I presume you have some opening remarks that you may want to make before we go straight to questions.
Well, thank you, Chair. I'll perhaps begin and I'll hand over to Tracey. I thought it would be, Tracey, to be helpful to be here from an SPPG perspective in the context of the fact that I have done 3 weeks in the job in Belfast Trust, and you may have questions about the intervening period since the first cardiac surgery report came out and the interactions with the Trust over that period of time. And then I'm happy to say a few words just in relation to how the first few weeks have been in my experience. So I don't know if you want to say something first of all, Tracey.
No, I think you may remember I was here in June, just around the time when this situation was unfolding, and we talked then about an accountability and oversight process in line with our performance accountability support and intervention level 5. And what I can do today is to give you some information around that, should members wish, around what's happened in the intervening period and those interactions with the Trust prior to Jennifer being there, and our view from a departmental perspective as to how we think that's going. So I have nothing more to say just at the moment.
Okay.
And I suppose just from my reflections just on the first few weeks, I have had a very warm welcome into the organisation. I have very much got a sense of the majority of people wanting to draw a line and move on. That's not everybody, of course. I have a great sense of people wanting to distance themselves from poor behaviour, and they're very clear that that is unacceptable. Wanting to tell me about the good work that they and their clinical teams are doing in respect of their services. And I've had the opportunity to be out and about a lot in the past 3 weeks. I did receive the report on Tuesday afternoon, and obviously I've had the opportunity to have in-depth conversations with Peter and Jennifer. And one of the things that I wanted to do yesterday, whenever the Minister published his statement and the report, was to put something out to the organisation, which I have done. And it was in recognising that there are a number of people, as Peter has said, who have been very damaged by some of the processes in the last few years. And I want to recognise that and acknowledge it and say to those people that they have been heard and that I'm really sorry that they have been placed in that situation. I know that there are people who have felt unsupported and very let down by some of the processes that have taken place. And so there are almost 2 strands of work in terms of a lot of people who are wanting to draw a line and move on in a positive way. And yet we do have to find a way to look at how we support individuals who have been deeply impacted by this. And I'm sure I can talk about that in a little bit more detail. So happy to pause there and take questions, Chair. Thank you.
Okay, and I actually wanted you to make your opening remarks before I actually welcome you and congratulate you on your new role as the new Chief Executive. I mean, we all wish you well in the role that you do. I mean, I have to say, I've been the chair of the Health Committee for 8 months, and a lot of that time has been taken up with issues within the Belfast Trust. So it's in all our interest that there's change, that there's new procedures, new policies, and that we have less of the issues that we have been dealing with over the 8 weeks. So everybody wishes you well in your new role. Jennifer, you had the opportunity to listen to Peter and Jennifer previously. So you've now seen the report, you've seen the recommendations, you've heard us asking questions in relation to the recommendations. So can I ask you to set out first of all, your thoughts on the report, and also your view on if and how you and the Trust will implement the recommendations?
Okay. First of all, I do think that Peter and Jennifer have done a really, really great job. I think the report is very balanced. They've acknowledged in there where there are many examples of very excellent behaviour and where people have intervened and addressed situations, and they have clearly looked at where all of the areas of concerns are, and we've explored that in great detail there this afternoon. In terms of the recommendations themselves, I fully accept the recommendations. I think they're very helpful to me. I embrace them fully. I know the chair of the organisation feels the same way that I do. We have shared the full report, obviously, with the Trust Board. There's a formal process that we have to go through in terms of considering those as a Trust Board, which we will do. Certainly it will be our recommendation that we accept these in full. I fully expect the Trust Board to do that. That's certainly the messages that I have been getting. So there's nothing that I would dispute in terms of the recommendations. We do need to take time to consider them, as I say, as a full board, but not just the board. As a wider senior leadership group across the organisation, with our senior medical staff and other heads of departments, and with our trade union colleagues as well. I think the action plan that we develop should be one that is done in partnership. I don't think it should be one that is just developed by the Trust Board and handed out to the organisation. This is part of the people and culture approach that Peter was talking about. We must do this with people and not to people. So I am very keen to get out and about, as I have been in the last few weeks, and work with people to look at how we pull together an action plan together. There are things that we need to do at pace, of course, and I can make a start on that, but there are other things, particularly in and around the people and culture strategy, that we really need to do together with colleagues.
I'm glad you mentioned the trade union. So you're only in your role a few weeks. I was going to ask you if you had any engagement with trade unions yet in relation to this piece, but other pieces going on, but particularly the cultural piece. And because you'll have heard us asking Peter previously about other issues beyond the cardiac surgery unit. So I'm just going to ask you, what kind of engagement you've had with the trade unions, and what is your concerns about issues beyond the cardiac surgery unit within the Belfast Trust?
Yes, I have had engagement with the trade unions. There's a very regular meeting actually with the executive team, and it happened to take place yesterday morning. The report was obviously not published until 2 o'clock in the afternoon, so I alluded to it and I gave some information at a very high level, but obviously because it was not published I couldn't go into detail at that time. That's certainly something that we will follow up. I found it was a very constructive and positive meeting, really good exchanges between the executive team and the trade union members that were there. I think there's a real genuine desire to work in partnership. I heard about various examples of work that is ongoing where you have trade union members as part of working groups of various projects that are ongoing. So it is early days for me. I do have a meeting with the chair of trade union side coming up, and there will be further meetings with them as we work our way through all of this.
Okay, and previously you talked about working at pace, so yeah. I understand there's a procedure, the board has to get a look at that in terms of what outcomes will be from that, but in terms of what you envisage working at pace over the next 6 months, what do you think can be implemented to make a difference? Because, as I say, the public have been hearing constantly about issues with regard to the Belfast Trust, and the staff have been hearing issues constantly about issues within the Belfast Trust. So, working at pace to kind of restore confidence over the next 6 months, what would you envisage are the key priorities, and what can you achieve in the next 6 months to a year?
There's some very practical things in there in terms of reviewing the HR function. That's certainly something that, while it may not be completed, would certainly be underway within that period of time. The same in relation to the recommendations that have been made around the structure. That's something that I would hope would be completed by that time as well. So those are the types of practical things that I think can be got underway at the same time as we're having an ongoing engagement right across the organisation.
And then one last question for you before I maybe speak to Tracey. Like, there was recommendations about the size of the board and the number of interim positions as well, and the structure. So, I mean, is there plans in place, for example, with interim position? I think it was 25 interim positions, which to me seemed like a lot. Like, is there a recruitment process? Will those be filled? I mean, because I would imagine at that level, you know, if you're doing something else over and above what you're currently doing, or you're doing something short term, it's not the ideal scenario.
No, ideally you want to have a stable team with permanently recruited people. I understand why there has been a delay in that. Separately, there has been a review around senior executives, so we haven't gone forward in trusts to appoint permanent posts in the last number of months. I suppose the other aspect of it was my appointment and coming into role, and it was the right thing to wait until the organisation had a new chief executive in post, and that I have the opportunity to shape the team that I want to see there. I accept the recommendation about reviewing the board structure, and in particular looking at the size of the executive team. That is something that I would very much want to look at going forward. I did have a different structure as the chief executive of the Northern Trust, which was more in line with the structure that was suggested in there, and that's certainly something that I would be looking at going forward.
Okay, sorry, one last question for you, because we have an interim board chair. I mean, is there any indication of when that position will be filled permanently?
Yes, you might want to answer that a bit, Tracey.
Yes, I think there was a memo went round the department the other day just setting out the number. Too much longer, but sometimes these things do take a bit of time, but hopefully within that next 6 to 8 months position there should be someone in post. But I would pay absolute credit to Patricia Gordon in the meantime. Having worked with Patricia over the summer, she has been really positive, willing to have the difficult conversations, and really has been helping to drive that process along with Maureen Edwards, who was the interim CX. So, you know, I think it's in safe hands at the meantime, and really welcome Jennifer's appointment.
Okay, so Tracey, in terms of the department's role in this, now that we've got the report, so the department has raised the level to level 5 for the Belfast Trust. Moving forward with regard to these recommendations, what role will the department play in terms of support and overseeing the implementation of some of this?
There's a number of strands, and I would point out the department, there's 2 recommendations within Peter McBride and Dr. Hill's report relating to the department, which I can talk to you as well. But at the minute, how we had set up the oversight, the enhanced oversight arrangements due to the level 5, I advised in June, was in 2 parts. One was very specific to cardiac surgery because of the very specific actions and the need for an action plan specifically for that. But we did recognise at that point that there were elements of the report at that time from DCO that probably had wider application in terms of governance and processes and accountability. So we split it into 2 parts, slightly different membership for both. But the chair and chief executive and the interim roles have been involved in both of those. We've had 17 meetings since I was with you in June. Those have happened on a fortnightly basis, and we've been taking them on. So they've been long Friday afternoons where we're working through with the team. So we have an action plan from the Trust on the cardiac surgery specific elements. We have also on the 26th of September had an open meeting with Patient Client Council and RQIA, because both of them, PCC, have been involved, and they have other comments to make about other elements of this which will be helpful to the Trust moving forward. We've also thought about how do we get to that next stage. So for me, I have shared a letter both for myself and Aidan Dawson, my Joint Commissioner in PHA, Chief Executive, about what we would think we would want to see before we'd be in de-escalation. So that's the piece of work from now to then. And we have sustained levels of stability in the cardiac surgery. This is what started it. We want to see that, and that will include all of the recommendations. I want the significant proportion of the recommendations implemented before I could even consider at that stage and sustain positive outcomes. We monitor that by a number of ways. We have a SITREP process which continues on a weekly basis with the Trust, and we monitor planned surgeries, cancellations, reasons for cancellations, waiting list, safety and quality outcomes. There's a wide range that happens on a weekly basis, so we're over that. But we also want independent oversight. So I don't want to come to the end and come to you and say, I have seen from the Trust has told me, here's all the implementation. That's not what we've agreed this would be about. We've had experts to support the process to date, both Jennifer and Peter, and also Mr. Steve Livesey, who was one of the report authors, who's been really helpful to the cardiac surgery team in developing their action plan, that challenge, that check. Is that what you meant? Is that what you've seen? Is this going to address what you saw that it wasn't there? But also with RQA and PCC, and we've had a conversation, notwithstanding RQA's statutory role to inspect if they feel that that's appropriate, but also about at an appropriate moment we'll have a conversation about how that might work. So we'll want independent assurance, and we'll have to play that in when we feel there's an appropriate body of work done for cardiac surgery specific recommendations. So all of that will be part of it, but it will also be that level of assurance we're receiving from the Trust on that people plan. And there are, we had a really good presentation from the HR team recently about the staff engagement. So Trusts will routinely, all arm's length bodies will routinely consider culture and what they do on a normal basis and whether that needs to be enhanced with this process and underpinned by a people plan. So there's lots of different things we'll be doing, both from the practical in the cardiac surgery. There are 16 recommendations, if I can remember my numbers, 15, from the DCO report. An additional one the Trust added themselves, which was work with NIMDA. And there were 7 recommendations from the previous Royal College of Surgery review back in 2019 that were similar, some of them in nature, to some in the DCO reports. So clearly the work done hadn't held. Those are all on a big database for us. We'll be looking for implementation evidence, independent assurance across all of those. We're meeting tomorrow, part of our fortnightly, but we will consider now that this report is in and Jennifer's in post, how we'll take that forward. It's likely to be slightly different and slightly different membership, but that will continue in a very regular oversight process.
So, I mean, notwithstanding Alan's comment about expecting everybody to get on well with everybody, because I don't think anybody would expect that in any work scenario, but in the health sector, as in any other organisation, you expect function to be existing within teams, and if it's not there, you expect management to step in and ensure that it does. So, Jennifer, you'll have heard me asking Peter and Jennifer previously, my concern that in their report they are still reporting dysfunction within the cardiac surgery unit. So we have the cardiac unit action plan, we have the 3rd or 4th inquiry report into that unit. We're a number of years down the road. So, I mean, how concerned are you that there is still dysfunction? No, there's a difference between not getting on and dysfunction in a very important unit of our health system.
Absolutely. That's why we continue the situation reps, because what we're wanting to see is while there may be individuals who have difficulties with each other, what is the outcome of that from a patient perspective, and what is that doing to the level of activity, the level of the outcome for the patients? So there's a significant process continues around that, and we'll keep that going. We have seen nothing since we set that up to give us more concern, but that doesn't mean there isn't something from a culture of the team and that working well together and being civil and understanding the processes that Jennifer won't be addressing. It's certainly set out in the action plan, but we've had quite a lot of conversation about, and how do we know it's worked? And how do we know that it's resolved itself to a degree that we're not going to be back here in next year or the year after? So that's been a lot of what we've done. Listen, that's going to be tough. I don't think any of us think that, you know, if there's been issues that have been there for a while, that it resolves overnight. Culture improvement change takes time, and we understand that. From a departmental perspective, we will be there to support Jennifer and the team, and also to challenge Jennifer and the team in that space. But we're looking at it from very much from the patient perspective. We will be overseeing the outcomes of those reports for the staff and ensuring that those have been picked up, and also wanting to see that those governance processes, which should overlay this right up from floor to board, are well in place and that they are as good as everyone would expect them to be, including some of the recommendations made in the report.
Could I perhaps add to that, just specifically on that bit about the relationships within the team? I think we're all agreed you don't change that overnight. Without getting into very specific detail, I mean, it has gone from a situation where you would have people not willing to be in the same room to being part of a functioning multidisciplinary team. So that is progress. I think the appointment of the interim clinical director from out with the unit has been a hugely important move. I've had one meeting with him so far. He's also met with the chair and obviously our medical director. I'm really impressed with this individual, the reflections over his own career, what he believes he can bring to the team, what I believe he is already bringing to the team. And obviously one of the recommendations is that I meet with him and review all of this at a 3-month and a 6-month point. So it is not something that we can afford to be complacent about in any means. And I fully understand the concerns that were expressed by Jennifer and Peter and why they expressed them in the way that they had. And it's something that we need to keep a close eye on. But I do believe it's an improving situation. I think it is worth saying as well, we have had interaction with NIMDTA, the Northern Ireland Medical and Dental Training Agency, and GMC, who were doing a review into cardiac surgery, and that took place earlier today. I got a text about it while I was sitting back there. They're very clear that there are no patient safety concerns from their perspective. There are no concerns about trainee safety. And it's worth saying as well, we do also report data into a UK-wide database in relation to cardiac surgery outcomes. And 2 of our cardiac surgeons are in the top 10% in the UK. So I think it's worth saying that there's some really incredibly strong individuals in that team.
Okay, thank you. Linda?
It's a tare. I think if they can be capable of being such gifted surgeons, they should have some sort of people skills. But that's an entirely separate issue, not for us to get into. I think others have that job to do. Listen, first of all, congratulations, Jennifer, on your new post, and I wish you all the best. Obviously, I've worked very closely with you in the Northern Trust, and we're sorry to lose you. So I do really wish you the best. You have a lot to take on in terms of the Belfast Trust and the challenges there. But I suppose my first point actually would be, this is not unique to the Belfast Trust, and I think Peter may have alluded to this in his last remarks. I think that this, certainly you would get some of these behaviours, maybe not to this extent in a single unit between, I suppose, maybe people who are so central and integral in the team and what would be essentially a small team, but it does exist right across the region. So I think that Peter's last remarks around this, the learning from this needing to be taken. So there's a wee question in both of this, or in this for both of you, Tracey and Jennifer both. So we now have the committees in common. So that's an opportunity. You said that some of the recommendations that are in this report are things that you already had in place in the Northern Trust. Why, in the name of God, are trusts not in this day and age saying this is better? And I understand the committees in common is a very new process, but there was some work going on between trusts, and I just don't understand. Like, we have a small number of chief executives, and I think that they should be working together and they should be saying, here's a problem we're having. Why are you not having it in your trust area? Why is it not, crystallising in the same way? So how do we work that out better? So I just would like to get a sense of if the committees in common is an opportunity to actually look at these recommendations and see, can they be implemented actually right across all trusts? Because I did ask this question before around what are other trusts now doing to make sure they don't have the same type of issues. Because I can tell you 100% some of their teams do.
I'm happy even to start. You're quite right. There is learning for others in this space, and while I don't have anything on my desk that looks like the cardiac surgery Belfast issue particularly, I do think there's an awful lot of learning. I've actually asked, we have a senior leadership group where I also attend, so committees and commons very much trust. We can be in attendance, but it's a different procedure, but we have also asked to be able to discuss this and some of the interim learning with all of the chief executives. We have departmental officials there because, again, there are 2 recommendations for the department within this. Now, they tie into pieces of work which are probably already underway that you'll have heard about, the Being Open framework and other things, but it's a timely moment for a check in that process to see, does this tell us something different than the direction we're going in, and we will be taking that forward as well. We were having a conversation earlier this morning about just how we might do that and how do we check ourselves in that process, and how do we give the Minister the assurance that we've done what we need to do from a departmental perspective. But I think there's an opportunity to consider the learning, and actually it's been an ongoing conversation we've had all summer. So not just now with this report, but it's within that whole process about what's the learning that others might need to see. How are each of our trusts considering culture? And you can calculate almost an engagement score. You may have had some of the surveys that come out in past if you've worked in health. How's that done? Are we all doing the best? Are we benchmarking ourselves nationally? Are we really looking to be the best across the HSC? So it's been an ongoing conversation, but to give assurance, that's certainly part of what I've been discussing this week since I've seen the report, is about what do we pick out and how do we do that. And I know Jennifer will be a very open partner and transparent in that process with us, with other colleagues, not just in trusts. We've other organisations other than trusts, but it may be more pertinent there because there's more of our staff there, but across all organisations. We get our commitment to do that. The Minister's very committed in that space.
And I think for me, I shared the recommendations as soon as I had them with my chief executive colleagues. We will be discussing this at our next meeting. I think just a little bit about the focus within each organisation. I mean, ultimately we are all arm's length bodies of the Department of Health, but we all have our own trust boards, we all have our own governance structures. I agree that the committee in common gives us an opportunity to move closer to perhaps a single set of objectives that we each have. So each organisation currently has slightly different objectives, and everybody will have something around quality and safety, something around the resources, something around partnerships. A number of years ago, we chose in the Northern Trust to have a huge focus on people and very much a people and culture committee. Different, as I say, different organisations do it in different ways. And it's been one of the best things that we ever did in the Northern Trust. And just that strong focus on your staff, on your people, and all aspects of that, how you recruit them, how you train them, how you support them, how you challenge them to be even better, how you support them whenever things go wrong, right through to how do you deal with very difficult situations. And there's no doubt that bit about how people work together and the team dynamics, because we absolutely know, as it was alluded to earlier on, when people work well together in a functioning team, if it's in a clinical area, their outcomes are better. If it's in another area, often the productivity is better. The innovation is better because people trust each other and have the confidence to experiment and to try new things. So I very much echo what Peter said earlier on about focusing on people, because I think if you get that bit right, the rest will follow.
I agree with you. I suppose that's the point I'm trying to make. I understand that every chief executive, and I understand your own caution because you're chief executive of Belfast Trust and you don't want to impose what you think on other trusts. But I think Peter's remarks are right. Every single trust needs to put their people at the heart of it, because they are the people who are dealing with the people, you know.
And if I might add, we are going into our process at the moment of reviewing what we would put for the trust objectives for next year from a departmental perspective. So there's always a planning process, and we've had a bit of a conversation about how do we get this in, what's the way we'll do it. Doesn't mean that everybody has to do it exactly the same. I think you want the best outcome, and everybody could be at slightly different levels and at different places. And I actually worked in the Northern Trust, and I know the people plan that was there at the time, and there was a big focus. So it's about looking at the best of what you have and where you are and where the issues are. But it's about getting to that outcome and making sure that it's been driven and it runs through everything you do. I mean, I'm trying to drive performance, with Jennifer and team, with all of the other CXs and team, when we're pushing performance, absolutely. If you have a good team, I mean, evidence shows you absolutely, and that to use that phrase, psychological freedom, to try and to make a mistake and to have learning from it has to be part of how we operate going forward. So where it's fallen short in places, and I would also set it in context, while absolutely agreeing with what we've got, you know, there's evidence every day of great practice and teams being really engaged and really delivering great work. So we have to bring everybody up. So it might look different in each place, but the outcome needs to be the same. So I think that's where the common learning needs to come in, but not necessarily the same way of doing it.
I accept that. Just, I suppose, the same kind of question that I asked Peter, although it probably wasn't really for him. It's how do we now track the outcomes in relation to the recommendations? And I suppose I'm going to not ask you to define that right now, because you've said, Jennifer, there's conversations to be had with the Trust Board and others. But what I am going to ask is that you have conversations with each other between the department and the Trust and everybody involved in this, in order to give us as a committee a plan that we can actually track the recommendations and the outcomes, because these things become so complicated. You know, department has one part to do, Trust has another part to do. Then they'll say, well, that's actually for the cardiac unit themselves, and they'll do that. But so I just think we need a simplified way, because I think this is what's happened with previous reports. Everything gets lost in the ether. You know, somebody's dealing with everything, but we don't know who's dealing with what, and it's really difficult to track, and that becomes impossible for yourselves and us.
I would agree with you. I think what's different now is the support and intervention framework, and it's a very contained process that we have. So when I talk about the 17 meetings, we have now an action plan for cardiac. Now Jennifer will wish to reflect on that as she's come into post, and with the knowledge now of the report that's come out that we've been talking about today. But that is a set of actions which has all of the recommendations, those that we thought, when we go back to the Royal College of Surgeons report, the new ones from the DCO report, and the additional one the Trust themselves have added in for NIMDA. That is being tracked. What we are doing now is we will ensure that from our, because we have them all sitting in our database, we'll be tracking them, and that's more for us, for the independent assurance. The Trust says this in the latest progress. Do we see anything with our monitoring that would either agree or disagree with that? So we have a process sitting behind that, and it's a very clear process that there's no surprises between the department and the Trust. And what's different now is there'll be two for the department in that I will have to work a process with Permanent Secretary, and we'll ultimately have to be reporting to the Minister on those two specifically. So we will track every single one of them. I think then it's about how we give you that information, and I think when we've considered the de-escalation process, I'll have to show that evidence. I will want that to be transparent, that the judgment that we make, particularly within the Commission and with the support of Chief Medical Officer, Chief Nursing Officer, all those others who are involved on each of the elements, we will want to be transparent in that. There should be nothing hidden. I think we've been pretty transparent to date, and
so we'll be able to see what the de-escalation process is based on. Is that what you're telling me?
Absolutely. Okay. I would imagine the Minister on this one has committed to being very transparent, hence the open of the report now. Timing of that was probably quite difficult for the Trust, but we wanted to make sure that when it was there that everyone saw it transparently. But Jennifer will have to then take that through now with all of her team and to take that forward. So there's a few conversations about making sure Jennifer had enough time to be able to talk to her senior team and her board. But the action plan, Jennifer might wish to speak to where that's gone on cardiac. That will go through Jennifer's Trust board before it comes to me, and then board papers obviously will be shared.
And obviously I talked a little bit earlier on about how I want to develop the action plan, that we develop it with people across the organisation. I think that's important. So it's also very important for me that I'm signalling out to the organisation how we are making progress. That has to be very open and visible to everybody in the organisation as well as to all of you.
Well, I appreciate that, and I suppose that I think the biggest challenge for yourself in terms of that, I appreciate that your plan is to work with the unions and the people and everybody else, but it's about breaking down that culture at every level, because the unions need to feel when they're in the room that they have equal say, that they're genuinely part of the conversation, that they're not there so they can say, well, the unions were there, so we're covered. So it's about making sure the unions, and that they are reflecting the staff views and ensuring the unions are going back to the staff. So I think all of that is really important, but I think those are all the questions that I have for now. But I suppose for me the important part here is that how do we now track it, and the accountability, and making sure that we're scrutinising the accountability of the Trust on the department around this.
Okay, thanks, Lynn. Yeah.
Thank you, Chair, and thank you. And like other colleagues, Jennifer, you know that I wish you every good wish in leading this organisation. It is a huge, complex organisation, but it is also a regional centre of excellence for Northern Ireland, and every one of us has an input into trying to make sure that it's the best it can be. Can I just follow up Linda's point about tracking? And maybe Tracey, you could answer this. So we had the 2019 Royal College of Surgeons report, which reported, as if I picked you up right, almost the same issues that the 2023 report picked up on, and the 2025 report, and now the report that we have on our desk today. Why did the department not take any action before now?
I think to remember that in the 2019 review, I think the report was 2020, and the recommendations that were there, they were cleared at the time by the GMC to say that there was sufficient progress. Now I can remember when I was with you in June, I'm saying the question to us is why didn't it hold? And I think as we're seeing now that relationships probably meant that it didn't hold as well as it needed to, and that's why we were back to where we were again, and we're not quite back to the beginning because there were other elements that did hold. So I think it's not about, it was signed off, General Medical Council saw the progress and it was cleared, and I think that's within the Trust's action plan, so it's difficult. And then we've had a situation again which has meant this has come to the fore again. So that's why when I talk about de-escalation, it's about truly understanding that this is different this time. It has to be. And we don't want to be back here again, and that's about all of the assurances that we have. But we are dealing with individuals, and sometimes unfortunately things happen, but with all of the work that will be going on in the people strategy, the culture, all of those elements, I do think it should make a difference, but we'll have to track to make sure that it does. And we're in a very different process now in the way that we're doing. So I can just give you an assurance from myself and from Aidan in PHA that this is something that's top of our agenda, and we will be tracking this through. But I don't want to get to the end and say at Christmas there's X number of recommendations and I'm content. This is about sustaining it, and it's about how do we take that through. That's the conversation for tomorrow with Jennifer and with Patricia. That we'll have to have a conversation about how are we all going to, this has to be a partnership, how are we all going to get to the level of confidence that we can give an assurance to the public, to the staff, to yourselves, to the Minister, about this is sustained and that we think it's in a much better place. Does that mean in a period of time that something could happen? I think we'd have to all be honest. Things happen every day, and it's about how we respond then. And it's about knowing that when something, and if something happens, that we've got the right procedures, that the staff are absolutely assured as to how they operate them, and that the organisation will have a consistent response to those procedures. So it's all of those things have to happen, and they all need to move forward in tandem, not just one at a time.
If I may, I think there has been a very structured and robust process put in around cardiac over the last number of months. And I think also with the appointment of the interim clinical director, that's been a really important move. There's a formal recommendation for me in here in terms of following that up. But even without that, this is so important that this needs to be tracked at our trust board meeting. And I fully expect to be held to account by SPPG and the department and by yourselves in relation to this. We cannot afford for this to slip back again. So it's, to me, this is constant gardening and constant attention that needs to be given to this type of thing.
So just a comment in relation to it. I mean, the cardiac surgical unit is one of many issues across the trust, and my understanding is that the chair of the trust briefs the department every week or every month in relation to issues that are ongoing. And I can't help but feel that not just surgeons and clinicians across the trust were let down by what Peter has described as an abuse of power within the trust, but you let the Minister down by allowing it to escalate to the extent that it did. And then, we're all holding our hands up and saying, what can we do now? I don't understand the dynamic between the department and the trust. But I do think that if we are to go forward in this, and we're not to actually end up in the same position where the minister has to intervene and the minister has to do whatever, there needs to be a much, much more robust process between those two. Can I just skip on, because I have a couple of things that I do want to ask. And Jennifer, one of the things that struck me very much in this report was the number of SAIs that were outstanding, and the number of mortality reviews, over 900 at November 2024, that were still not completed. Can we get an assurance that those SAIs, because we actually attended a meeting here with people who had outstanding SAIs with the Trust. This is not just harm because of the nature of an SAI process, but this is ongoing harm to families. And I came out of that meeting, I must say I was quite emotional. I thought it was one of the toughest meetings that we have done, and I would really like an assurance from you that these SAIs will be completed. I actually attended an SAI review a few weeks ago in the Belfast Trust, and quite frankly, by the time I came out of it at 5 o'clock on a Friday afternoon, I was exhausted, and I was only there to record what happened. This is a matter of ongoing harm. And it really needs to be dealt with, because delaying this issue is harmful on top of harm already caused.
I fully accept that. I think it is something that a lot of us struggle with in terms of SAIs and having them completed in a timely way. And partly that is to do with resource and how we support teams to make sure that it is done properly. I completely agree with you that it's such an important thing for families that we do that in as timely a way as we possibly can. It is part of the support and intervention framework on which we are held to account by the SPPG. So I can assure you that there's a huge focus going in on this area.
If the Trust is held to account by SPPG, why do we have an unusually large number of SAIs not completed?
I can't speak about the history. I can only talk about what we're intending to do going forward.
And I appreciate that, Jennifer, but I think it also, I must make the point that it would have been helpful if some of the leadership team that were actually in charge of all of this were here to actually answer some of those questions too. I appreciate that you want us to focus on the future, and I want to focus on the future, but as I've made my remarks to Peter and to Jennifer, unless we expunge the hurt and the harm of the past, we're just going to go round in circles. We'll be back talking about that Royal College of Surgeons report again and again and again. And anyway, I can't really understand. Can I move on? Not that I'm fixated on it, but I think it's important. To this process, HPS. On the 12th of June, we had a meeting with the senior leadership team of the Belfast Trust, and I asked questions about the MHPS process. And on that day, I'm reading the Hansard. On that day, I asked about the process, and your medical director jumped in to say that there was already a review underway and had already been commissioned by the chair of the Trust in relation to MHPS. I asked, when did the review start? Mr. Hagan said it had just started. And then we went on to talk about the need for external input into that review and how that review would be conducted. So, having heard nothing from the Trust about that, I wrote to the Trust at the beginning of September, and I asked the Trust, so you've been conducting this review, as you stated, on the 12th of June. Could you tell me what the outcome of the review was, please? And I got a letter from the Trust on the 8th of October, which said that the review had not started, that they had not appointed a person to conduct the review, and that the review was no longer going to be an investigation of individual files, but it was going to be an anonymised review of a select number of files. Do you think that the Belfast Trust should apologise for misleading the committee and correct the record?
I can speak from my perspective. The latter bit that you outlined is what I understood was going forward. So an external company has been appointed to carry out a review, and yes, it is my understanding that it is a randomised selection of a number of cases to determine whether they were carried out according to the appropriate process, that the review period will take approximately 12 weeks, and then we'll be in a receipt of report. So the external company has been appointed, and that review will be starting. It's my understanding it has not yet started.
Okay, do you understand why I am aggrieved that we were told on the 12th of June, it's in the Hansard, I'm not making it up.
No, I appreciate that, and I fully understand.
Has actually started, and I think that the Trust should, as a corporate body, and this is not a personal issue with you. You weren't there, but this is why the leadership team that was there should be here to answer questions. We were told the review had started very clearly. Mr. Hagan, it has only just started. When will that review start? Mr. Hagan, it has only just started. I mean, and this is part of the problem. This is part of the problem. So I do think that's important, and I think that the Trust should consider that position in relation to this committee. And
can I apologise to you, Diane, on behalf of the Trust? I appreciate you may also wish to hear from others.
Well, it's not a personal issue.
No,
this is a statutory committee.
Yes.
And giving information that is inaccurate to statutory committee is an issue for us to deal with. We need to understand that when the Trust make a statement, that the statement is correct. Can I just, again, on the issue of MHPS, the figures at page 13 in the report, and indeed the sentence explaining them, says that there has been a steady increase in legal claims against the Trust over the past year. My understanding that those are in relation to MHPS. So how many claims have been lodged? How many claims have gone to court? How many claims have been settled? How many claims are still within an industrial tribunal situation? I understand you don't have those figures, but I know there's someone writing notes at the back, and it would be great to have those figures. And could I also ask how much has been spent by the Trust in settlement of claims, and how much is pending in settlement of claims? And can I ask a further question, which is, where did that money come from? Because we already know that at 63 million for the management costs for the Belfast Trust are more than and this is from a question I asked the Health Minister, are more than the combined costs of the Southern and Western Trust. So the Southern and Western Trust put together don't spend as much on management as the Belfast Trust. And we understand from a management issue, we now have a figure that's going to be quite high in terms of settling legal claims. Now, can I make it absolutely clear? Everyone has the right to pursue their own personal employment issues in every way that they see possible. But my view is that if the Trust had managed this properly, if the Trust had this, we wouldn't be in this position. So it would be great if those figures could be sent to the committee. And I just ask one last question. In relation to the issue of this kind of idea that Peter expressed of kind of things are lost in translation between managers and board, and then decisions are taken which to me are inexplicable. So I understand that the water usage group did not recommend that the handover of the Royal Maternity Hospital take place. That's my understanding. But that handover still went ahead. We are now in a position where that was, I don't know, January, March 2024. We're coming up soon to 2026. And the last I heard when I asked a question about this was that the solution favoured by the Trust could take another 2 years and perhaps 10 million more to actually put right. I really need to know whether or not the Trust Board actually got all of the information that they needed in a way that they could understand it, so that they were making a decision that was clear and coherent. And I know you can't give me that, and again, I'm going to make the point again. This is why we should have had people from the Trust leadership here who understood what happened. And I'll just make a final point, and that sounds as if I'm on a bit of a rant, but maybe I am. It is a habit. A final point in relation to this. The Belfast Trust has harmed people. It has harmed people really seriously. And I have spoken to people who have been harmed. I've spoken to people who've left the Belfast Trust. And if we're to build a really good regional speciality in Northern Ireland, goodness me, we can't afford for that to happen. And I've spoken to people who feel that their careers are just over. I do not want to see the legacy issues hived off and said, well, that's for another day. You cannot go forward unless you make right.
I agree with that. And the message that I put out to the organisation yesterday morning, I acknowledge that. I agree, Diane, that we cannot let that go. I agree that there are people who have been damaged. I think there need to be individual conversations in relation to what helps you to move on. Can we help you move on? What will that be? And it won't be the same answer for every individual person. But I agree with you that it's hugely important that we address that as an organisation.
Okay. I look forward to someone coming back and having a conversation around that, because I think it is massively, massively important. But I'd really like, in a reasonable period of time, a conversation around the issue of outstanding SAIs, which I believe are really causing harm to people. Thank you.
Thank you, Danny.
Thank you, Chair. First, obviously, welcome to your new role. And like other members, we've had engagements in the past within the Northern Trust. And again, I'm sorry to lose you from the Northern Trust.
Thanks, Danny.
Can I just ask you, obviously, coming into this role, there are a lot of issues, as Philip has alluded to, that we've spent quite a significant amount of time dealing with in this committee, and they include capital projects, they include poor staff morale, and they, as we've heard today, a lack of confidence from the public because of various issues. But what are your key priorities? What are you focusing on?
People. It's people and culture. Because I do think it relates to every other aspect that you're talking about. There are things that we know are concerns in the organisation because of dysfunctional teams, and there are other things that are concerned where perhaps we have not trained people properly or not given them the support that they needed. So I am very firmly of the view that we focus on the people, and we have to do all of the other things, of course, in relation to performance management and financial management. But I think having people very much as the focus and how we wrap around them and support them as a good employer is very much at the heart of it. And just to reassure you, you know, I have had several briefings from Peter and Jennifer. I do have to say that the chair, the board and the directors in the organisation have been very open with me about the areas of concern. So I know where I want to focus. As I say, people is the big one, but that takes you into different areas and different teams where you will want to do a bit of work. But I think the organisation has been very open with me. I've welcomed the engagement that we've had with SPPG and the Public Health Agency as well, and the trade union. So.
One of the key issues that we've dealt with again and again here is our runaway capital projects. Yeah. And I just want to pick up on what Diane was talking about in the maternity hospital, and we've had various briefings and we've even visited the maternity hospital. So we've actually, I think it was February, we've actually been inside it. It looks fantastic, but the idea that women cannot have their babies there, you know, frustratingly is unbelievable that we're in this situation. Now we know that the Trust recommended option 2. The Minister had an investigation into that, which agreed with your decision. It's going to cost, I think, 6 million in and around.
I don't know the precise figure. Okay, it's around about that.
Sorry, not off the top of my head. Sorry, Danny.
Okay. 9 to 12 months' time. You're progressing a design team at the minute. When will the work actually start?
9 million, 6 million, 6 million. Need the glasses on.
So I can't say that specifically, Danny, in terms of exactly when that work would start. I presume that will be that design work will have to be complete and properly considered and signed off. And my understanding is it would take about a year to completion once the project actually starts. And
the design work, or does that include just the work?
My understanding is that is just the work, but I'm happy to check on the detail of that. But no, I'll not go into the detail because I'd rather just check the facts on that. Thank you.
I appreciate you might not be able to tell me this, but it was suggested that during the work for option 2, it may become apparent that is not enough. And you may have to revert to option 3. Option 3 was an entire pull out of the entire water system within the building. I think that was initially deemed excessive. But it may well be the case that this would have to be done. If that was the case, have you any sort of ballpark figure of price or length of time that would cost?
No, I couldn't answer that at this point in time, Danny. I'm more than happy that we get you that information.
Okay, no problem. Thank you. And certainly the other projects that are ongoing, the inpatient mental health unit at Belfast City, again visited by ourselves, I think more than 6 months ago as well. Progressing at the minute. Can you give us an update and the impact on the patients?
No, I'm sorry, I can't. I mean, 3 weeks into the job, I think that my understanding of today was to talk about this report. So I apologise that I don't have all of that information to hand.
No, it may be my fault. Now, I noticed we had strayed into other areas, and I know there are quite a lot of other areas that we wanted to talk about. So no, I'm happy to go back to the cardiac report.
Just to say that the Trust have responded to some of those type of questions and the pack in terms of timetable and cost, etc.
No problem. No, I'm happy to leave it there then, and I can pick up with you at other points.
Okay, thanks, Danny.
You're finished then?
All right.
Okay. Alan?
Thanks, Chair. Just want to step back into Dr. Hillam, Professor McBride's report, Jennifer. Danny had talked in his questioning to Professor McBride. He asked if there was any other cardiac surgery units in our trust. Obviously, you are a former chief executive of the Northern Trust. Was there any similar issues in the Northern Trust? And if there was, how did you deal with them?
I don't believe there were any issues that were that serious, where you had instances of throwing instruments, for example. So that was certainly not anything that I came across in my time in Northern Trust. I think it is fair for Peter to reflect that not all team members will always get on, and there are a range of interventions that you can do. So some of the things that I've been involved in the past are, for example, organising mediation for teams or team building events or other things to try and ensure that they can work together in a constructive and a positive way. But there is also something about good managerial intervention and trying to nip things in the bud before they actually go somewhere. And that is part and parcel of the people development and making sure that people are properly trained and having the confidence to go and do that. And I think often when things don't happen in that way, it's perhaps because the managers have not experienced that before and maybe don't have the confidence to go in and tackle that.
Just another comment on the report, stepping backwards again to the Minister's public comments of the 5th of June from memory. He had said at the time that he wanted the report to bring about tangible improvements in culture and working environment. Has the Minister privately put any timeline onto that in terms of tangible improvements?
And I suppose I'll come back to what I said about the de-escalation process. So the Minister has been given all of the minutes the whole way through the 17 different processes, and we've been keeping very closely engaged with the Minister. He has had a personal interest in this matter all over the summer. There's no timeline, and I think that's what Jennifer and the board within the Trust will have to consider now, how quickly some of the recommendations can be implemented, but then culture change as a widespread is a longer term, and that's not something that I think any of us can put a specific time frame. What I will give you assurance is that certainly the conversations Jennifer and I have had to date is that it needs to be shown with pace and urgency, but that doesn't mean that you get to the end point absolutely quickly. And I think that's the determination that you have to show to your staff, your trade unions, to everyone that's involved in that you're moving and that you're taking actions and you're continually working through. But I think we'll have to keep assessing it as we go forward by all of the independent experts that we have had to date, and may well play a part in the future, as well as RQA and others. But it's not something I think anybody's put a timetable. But my conversations, certainly within the department, have been about our tracking now towards how many recommendations are implemented and how can we independently verify those. And we're certainly keeping that. I mean, our meetings will continue to be very regular, but we haven't set a time frame on that. It'll be continuous assessment of that process. But I think Jennifer and myself and others, and we're talking, we need to see lots of activity in this area, and the people plan, Jennifer will want to reflect on what that looks like, and that will obviously set out some time frames around that as well, but no specific date. I think probably unhelpful at this point, because we'd almost say if you get there it's done, and it won't be, it'll be continuous.
I think there are some of the underlying actions within the specific recommendations that we can put a time frame on, and I think that would be important that we challenge ourselves in that way. But whenever we get to the culture bit, that's much longer change, as everybody has reflected. I think proper cultural change, to be quite honest, is a 3 to 5 year process. I really do think it takes that long. However, I was very struck by what Jennifer and Peter said earlier whenever you asked what change should they expect in a year, and that's where we should be looking for the green shoots or a few flowers. I think it is very much about what are people saying in the organisation, how does it feel to them, how is that reflected in a staff survey. So would people have more confidence to speak up and raise concerns? Are people confident going to their managers to engage about these things? That's the type of thing that I will be looking for, or that rather than something being escalated to the department or to one of you or to the media, that my office gets a call to say, I think you need to know about X, Y, or Z. Those are the types of things that I'm going to be looking for as well.
So then, Jennifer, say for example that in 3 to 5 years' time or less, members of this committee, whoever they may be in the next mandate, are still receiving pieces of correspondence and messages and emails from members of staff who feel that the culture still hasn't changed. Who then ultimately will be accountable? Will it be the Minister hoisted high on his own comments, or will it be yourselves?
I see myself as accountable and responsible. I am the accounting officer of the Belfast Trust. We will be in real trouble if in 3 years' time you're all still getting messages and that things have not started to change. I would like to see change, certainly in a year's time, we'll not have finished the process by then. But I think it is really important that we give hope and optimism to people inside the organisation. I started my comments by saying I've had a really warm welcome, and I really have. And I feel a real sense of energy within the organisation. People have welcomed this, and they are keen to get on and implement and to make change. I've heard people talk very proudly about the services that they provide, despite the challenges. And I think we have to grab that opportunity that people are affording us and to move forward together in the organisation. But I'm very clear. I'm accountable as the accounting officer.
Can I ask just a question then on the maternity hospital report that we have makes reference to the trust and their legal representatives are working with independent experts on issue of liability. Are we any further forward in terms of liability? Because I know Diane and many others on here have asked who will ultimately be liable for many months now, and we still continue to receive the same response.
Apologies, I can't answer that question, but I will certainly pick that up for you, Alan. Thank you.
Thank you. Nola?
Thank you for your answers. Jennifer, congratulations on your new role. Taken at a very difficult time, no doubt, but hopefully you can actually enjoy it, as well as providing the kind of new, fresh leadership, to be perfectly honest, that is obviously needed. I have a couple of quick questions. In our packs today, we had attached a few letters, some from retired consultants and some from your predecessor. And in one, this question's fallen on from Diane's, was about a review, an internal review, not the external review into the MHPS cases, but an internal review found that there was no misleading of the committee. And I just wonder, following everything that has been said, if you're willing to actually go back to look at that. The reason why I ask is because, you know, it is important that transparency is key here, and accountability in terms of moving forward, and recognising the role and remit of all bodies, ensuring that we do have that transparency element. So I wonder if that's something that you'd be willing to go back and relook at.
Yes, I honestly don't know the detail of what you're talking about, but I'm very happy to go and look at that. Absolutely.
Okay. Yeah, I think, it was just a letter that we had from your predecessor that said that an internal review found that the health committee was not misled. I think it's important for that kind of confidence that accountability will actually happen. I also want to ask, with regards to the MHPS cases, maintaining professional standards cases, why it's a sample review of cases, because from my engagement with people involved, there has been quite a high volume of counterclaims made, particularly from those who initially chose to put their head above the parapet and sign the letter to the trust back in October 2023, raising their concerns. And whether that external review, it might be more beneficial if it actually looked at all involved in this particular report incident.
My understanding of this is there is at that time there was a large volume of cases. That certainly has changed. The view was that doing a random selection of those cases would be sufficient to indicate whether or not we had a problem with the application of the MHPS process, and we can make a judgment after that on what we would need to do. So I think it's important, first of all, to determine, was there a misapplication of the MHPS process. I think we probably know from harm and hurt that has been done to some people that there are probably some that are of a concern, and I think the audit is an important step in that. And again, I don't know all of the detail, but I think that's certainly a first step in that process.
Okay. Well, after that, it would be beneficial if we could have correspondence regarding that. Just that we have had contact, a number of us on the committee, you know, from the October 2023 to December 2024 regarding complaints that were handed over either in person or emailed to members of staff within that unit, I'll call it, like the overall unit. And there were concerns about the way in which it was handled, and I think because they weren't dealt with in the previous report that we had talked about, that it is important that they are dealt with moving forward. I also want to ask if there's any negotiations, current negotiations between the trust and individuals involved in the collapse of relationships, and if any of these negotiations are about settlements. We have had, again, not verified by evidence, so that's why I'm asking whether there are any negotiations, because we have had contact that there may be negotiations between individuals and the trust and department level. With those involved, I'm assuming to move on or vacate roles.
Again, I will have to look into the detail of that. I am aware there are a number of cases ongoing on which I will require a brief, but I can't speak about that at this moment. Apologies.
And would those cases that are ongoing, not talking about an individual case, but would cases that are ongoing involve cases for settlement and disputes?
I don't know the detail yet, Nuala. Apologies.
Could we get the detail of that, and whether those do enter the high numbers? You know, we're talking 7-figure, 6-figure, or 7-figure sums. When do you think? Yeah,
I will take legal advice on this. I am not sure what I can disclose into the public domain, what I can disclose to you as a committee in closed session, for example. But I will take advice on that, because I would understand. I would imagine, given what you're describing, those are probably very sensitive.
Okay, and I understand if you can't do it in open session. I just think it's important that we do have a staffing complement that is actually gelled together, works together. And whilst many people have said that it's not putting patients at risk, I think it's still an important issue. I also then want to ask about the report from Peter and Jennifer previously, where they mentioned that there are current examples where the trust is intervening in terms of risks. And I think that may or may not have said behaviours. Can you expand on that at all? Obviously, you can't touch on individuals, but can you expand on what those interventions look like, and whether you have had the opportunity to really kind of direct those interventions, and would they actually be at board and chief exec level?
Certainly, I have been briefed on a number of different areas. These areas are also known to the trust board. There are arrangements that have been put in place. These are not to. The issues are not to the same standing as cardiac surgery. Therefore, the arrangements that are put in place are not as formal as reporting through, for example, to SPPG. But I'm satisfied that there are arrangements and interventions in place. And I would say as well, this is a watching brief. In an organisation of this size of 22,000 people, you are going to have things like this. And it is important that we keep a close eye on all of those things. And again, it's back to the people bit, encouraging people to come forward, hoping that they would have the confidence to share with my office, so that we can try and manage things as best we can.
And just my final question, because I understand we probably can't talk about a lot of the issues in public session, but do you think this report gives rise to the issue of a duty of candour, both at organisational and individual level? Because, you know, I mentioned Justice O'Hara and the hyponatremia inquiry back in 2018, and then we have Dr. Watt. We also have Muckmore Abbey inquiry, and it's not just health. I'm dealing with other issues too, particularly in my role as sitting in the policing board. But, you know, a lot of these issues that arise, a lot of them go back to duty of candour. In your role as chief exec, do you think that it should be pursued both at organisational and individual level?
I suppose I would reflect on what Peter said earlier, that we can have the mechanisms in place just as we have the mechanisms in relation to whistleblowing. That doesn't mean that it will work. So we have to find a way to ensure that people have the confidence to speak up. I think in relation to the duty of candour, my understanding is the Minister has committed to this in relation to an organisational perspective, which I would absolutely support. I know there's an ongoing debate in relation to that individual perspective, and there are different views on that. I mean, I'm very clear about my requirement to be completely open and honest with all of you. I think the thing that strikes me whenever I read through the report is where people were afraid to speak up. And I think that the thing that particularly concerned me, and I know concerned all of you as well, is whenever people witnessed either poor behaviour or witnessed issues of concern, and they still were afraid to speak up. So even though we have a process that allows that, they were still afraid to do so. And I'm just concerned that even if you have a duty, do we have the right support mechanisms that allow people to do that within that area? So I suppose that's what I would say. I'm very supportive of the need for an organisational duty of candour. I think we need to do something in the organisation to make sure that we are giving people the confidence that they can speak up and that they can be supported.
If I might even add to that as well, obviously we're watching the bill in Westminster, the Public Officer Accountability Bill, and as regards to individual duty of candour and all of the processes around that. But the department, I know, committee will have been briefed on the Being Open framework, and the consultation is closed. And the conversation we were having within the department today was with the opportunity that the report in front of us today brings, just to really rethink, just set that in place with the consultation responses, with what we're doing, to make sure that we have taken all opportunities that we have. And the other thing that I would say, and it was something talking to some of my SPBG colleagues recently, not in regards to this, but as professional staff, many of us, I mean, I have a duty already within my professional career, so we have responsibilities, and that extends down to the individual. So as Jennifer's talked to the organisation, setting the landscape out so that you feel confident that, you know, the processes will work the way we intend them. There is still a personal duty on professional staff to ensure that you do this. It'll be supported by duty of candour at organisation level, duty of candour if it comes at individual, and the Being Open framework, I think, will help to bring a lot of this together. So there's a lot of work in this space, and I think the report allows us an opportunity to just set it in along with the responses that we've got to the closed consultation. I know policy colleagues will be considering that.
And that would be great if that start, you know, the implementation of that coincided with the implementation of the Hillsborough law on the individual duty of candour, so that they can both work in tandem. But thank you very much.
Thanks, Nola. Arlia?
Yes, just quickly, and first of all, a very warm welcome into the constituency of Belfast. As a West Belfast MLA, delighted to have you in your new role, Jennifer. So congratulations, and I sincerely do wish you all the best with trying to oversee this critical piece of work. You've obviously come in at a very critical but timely point in time, you know, and hopefully you can make a change for the better in terms of where we are at the moment. But I'm just wondering, because obviously these issues have set in they've become embedded over a long period of time in terms of the bad culture, you know, how you follow process and how things are dealt with and managed. And I don't know, you know, would it be fair to say that some of it, even in terms of the processes, how they haven't been followed and how this bad sort of behaviour sort of crept in right across the trust, because you're talking about a lot of obviously individuals and people and departments, but also conscious that the health service has been under a lot of strain over the past number of years, and I'm even thinking about people that maybe would be taking up leadership roles and under additional pressure and strain, and can that impact on then how a person deals with their staff and deals with performance and all of those things. And I'm just not sure if there is any correlation around, you know, maybe the pressures that the trust has been under itself, and then in terms of how its staff and its leadership and its management have been able to respond and deal with things in the most effective way. So my question really is then moving forward and how you try and go about implementing the recommendations, which I know you obviously have to still discuss with your board and sign off on that. But what role do you, and I know Tracey has touched on it, but in terms of the role of the department and the SPPG, I do think it's important from the outset that as a trust that you are feeling supported from the outset to try and get a lot of this work over the line, short, medium and long term. And I'm not sure if that would involve additional resource. I'm thinking, for example, when we talk about the HR situation, and I don't know enough of the detail as you and your team would know, but even in terms of how you try and deal with some of those pressing issues in HR, is that taking on additional support, resource, finance to try and get the right type of team and people in place? I don't know. And I'm even thinking then about staff on the ground and, you know, even local team leaders right up to the more senior leadership positions. Jobs then obviously need to be doable for staff to carry them out. Local trust. So it's just maybe to get some feedback in terms of that with your conversations that you might be having in the time ahead with the department, with the SPPG, around how they might be able to practically, if there is practical ways in terms of resource or others, that they can support you really to try and get some of these recommendations off the ground.
Mm-hmm. Thanks, Orly, and I'll maybe start. Maybe Tracey might want to come in. I suppose I think first of all, just in talking about, you know, the culture right across the organisation and the poor behaviour that we've seen in some places, that is definitely not right across the organisation. And I've had, I've been out and about a lot in the last 3 weeks. I've joked to everybody that I've had no problem getting my 10,000 steps every day, which has been a good thing. But I have met with so many teams who are really proud of the service that they are delivering, even in challenging circumstances. And clinical directors who are telling me proudly of how well they're working as a multidisciplinary team, how they work with their nursing colleagues, with their allied health professional colleagues and so on. So I definitely don't think it is everywhere. And I suppose what that means then is moving forward, different teams will potentially be moving at different paces, and we just have to be mindful of that as we go forward together on the organisation. And some will need more support perhaps than others. I do feel support from SPPG, from the Public Health Agency, from the RQIA, from the department. And Tracey has talked about the support and intervention framework. It is deliberately so named. It is support and intervention. I think you're right to mention something like HR. I think it is under-resourced, and I'm mindful of what we talked about earlier in terms of management costs. Belfast is hugely big and complex. And because it is delivering the regional specialties, there is a complexity there and there is a volume there that obviously just doesn't exist in the other trusts. And of course we are health and social care, so we are delivering community services that are also regional services as well for the rest of Northern Ireland. So it is huge. And whenever we look at HR, in fact this is the case for all trusts, there was a GIRFT report done into what are often called the back office functions, and it did find that HR was quite light. So if we are wanting to do this properly and support our managers properly, I think HR is one of the areas that we need to look at. And there is a specific expertise in the world of medical HR. And it's crying out to me through here that that's where some of the concerns have come from in relation to that specialist knowledge around medical HR and how we make that as robust as we can in the organisation. I am really mindful about the very challenging financial situation that we are all in. So I'll have to think carefully about the resource that is needed, but I do think resource is needed in some places to try and improve things.
Okay, thank you.
Thank you.
And I suppose what I would add to that is that sometimes that conversation, and look, I spend a lot of my day worrying about the financial position and the pressures that we have. I'm going to set that to the side in the next part, but sometimes not investing in the right places costs you more in the long run. And I think that that's what we have to balance now. What we've done to date in the support and intervention, and the Minister was, when he calls a level 5, and this is the only time since we started it November last year, that there's level 5, it was very much about support. Even the report originally for the cardiac, that is a support. It's about being open and learning and understanding and not being frightened to look. But the sourcing of colleagues who are probably still behind me, if I don't turn around, Peter McBride and to Jennifer Hill, that support, the support from Steve Livesey, who has continued from that support. We have been hopefully supportive and equally challenging. There have been a lot of challenging conversations as we push this forward. And but I have seen after the initial, probably what I think I would describe as a bit of a shock moment, and that was difficult for the team. I don't underestimate that. Been really challenging for such a public exploration of a lot of these matters, and we have to be mindful people needed a minute just to let that sit. But they've moved really on. I've had very good engagement. We've had challenging conversations, but they have moved on respectfully over the summer, and I think in a much better place than we started the summer in. I think that management skills, both Jennifer and I actually had a conversation that we think that we talk about leadership, but actually sometimes what you need is good old-fashioned management and the confidence to take things forward and the advice when you need it. And I have worked in pressured teams, many of my jobs within health over the years, and it's about not losing your humanity when you have the tricky situations and knowing where you can get support when you need it. And often I rely on my HR colleagues and having conversations with my trade union colleagues and others even now. So it's about all of that confidence, and I think there's certainly something in it in complex organisations with the numbers and different professions of the employees that we have, it's not easy, and it's not something that we'll tick off and say it's done. Jennifer talked about constant gardening. It will need that in every successful organisation, and I was in the Northern Trust many years ago when that change was being brought through. It was something that was constant, and everybody understood it, and we all understood what we were trying to do together. I'm confident that Jennifer will be able to do that for the Belfast Trust, and we will be there to support and to challenge. That's our role, and to do that behind the scenes, but it's also that application across the system as well. You don't want another organisation to go the same if there are lessons that we can learn today.
Thank you.
Jennifer, Tracey, thank you very much for giving your time, and no doubt we will be engaging on this issue on an ongoing basis, so appreciate that. Thank you.
Thank you.
Okay, members, just moving on. So next item is the written briefing from the Department on the Maternity Review Report implementation. So I don't know if anybody has any comments on it. Danny, some of the questions, some of the issues were addressed. Do you want to go further than? I mean, we could go back, or we're going to continually get updates from them, aren't we?
So I thought that was part of what they were going to be addressing today, but
that was part of. No, we get ongoing. We've asked for updates specifically from the trust in relation to it.
But it wasn't anything that was going to be covered.
I mean, you ask the question, they decide whether they want to answer them or not.
Well, certainly I can follow up with them.
So anybody, any other comments on it? No? Okay. So item number 8, Adult Protection Bill, call for evidence response list. So can I refer members to the list at tab 8, page 75 of the main pack. There's a schedule of briefings in the memo, and briefings on the bill will commence at the next meeting, the 6th of November. So everybody content with that? Yep?
Yep.
Okay. Correspondence, can I refer everybody to correspondence index at tab 9, page 78 of the main pack. Any commentary on that? Anybody any issues you want to raise? No? Okay, so we'll just, where everybody's content with the actions as identified. We've mentioned breast cancer now, at page, I mentioned it earlier, so obviously we're all wearing our things. So, forward work programme, can I refer members to the draft forward work programme as tab 10 of the pack. Anybody any suggestions, comments, amendments in relation to that? No? All content? So there are a number of things there. I mean, I would draw people's attention to the visit to Fermanagh, so it's an all day thing, so hopefully we can have as many people present as possible. Okay, then. Sorry, that's wrong.
Which visit? Sorry, I couldn't hear what you were saying.
Oh,
there.
visit to Fermanagh, to the
to Fermanagh, yes.
the SWA, but we're doing other things. So, any other business? None. Date, time, place, next meeting, next Thursday. Sorry, not next Thursday. Thursday, 30th of October, room 29, 2:30.
November, Chair.
It is the 6th of November, sorry.
Sorry, this is 6th. Sorry, I knew it wasn't next Thursday, but 6th of November, sorry. I'm getting mixed up in my Octobers, and anyway, we're off next week. So.
I'm just
Okay, members, we're now going to go into closed session.
Committee Room 29, sound. 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 Committee Room 29, sound.